Good evening. Welcome to the fourth night of the PSRC 2021 Pentathlon. Tonight's program, coming to you live thanks to participants throughout North America, will focus on transplant and microsurgery and will be co-moderated by myself and Dr. Damon Cooney.
We'll begin our program with presentations of a handful of the highest rated abstracts submitted to the PSRC this year in the areas of microsurgery, reconstruction, and reconstructive transplantation. We'll then have a concurrent session with a breakout room on getting a job, and that will run parallel with a series of quick shot presentations. After that, we'll bring everyone back together for our invited lecture, which will be a discussion of the effects of COVID-19 on microsurgical reconstruction. And then finally, we'll conclude the evening with a panel discussion on combined VCA from two groups who are pushing the envelope in this field.
So first, we would like to thank our wonderful roster of presenters and faculty in advance for their participation. Before night 4, the penultimate PSRC Pentathlon presentation begins, here are a few rules and regulations for the evening. Please stay on mute out of respect for our speakers. Be sure to have your camera off while the speakers are presenting. You can turn on your camera for Q&A. Please participate in the Q&A sessions through the chat function. We want to hear your questions. Be sure your screen name includes your first and last name. And the PSRC Mentorship Committee is facilitating the breakout room Meet the Boss, Getting a Job, with mentors David Mathis, Amy Moore, and Justin Sachs throughout the quick shots session, which begins around 7:20 p.m. Eastern Time. Please take advantage of this opportunity to meet these leaders in our field, ask them questions, and get their advice. And then please plan to join us for our final night of the Pentathlon, which is tomorrow, June 11th, and will cover breast, aesthetic, and gender affirmation.
Be sure to follow the PSRC on social media and join us as a member if you haven't already. The Research Council is the preeminent research organization in plastic surgery, and there's so much innovation and high quality science that comes from our community. And I think it's really important to be a member of the society to promote that. For those of you who aren't members yet, we would love to have you involved.
And so now on to the presentations. We will now be hearing from the presenters of the top scored abstracts submitted this year.
Moving on, our next paper is ex vivo normothermic preservation of amputated limbs with a hemoglobin-based oxygen carrier perfusate. This will be presented by Brian Figueroa from Cleveland Clinic Foundation in Cleveland, Ohio.
Thank you for the opportunity of presenting our work. Today, I will be alluding to machine preservation of porcine forelimbs using a blood substitute. We have no relevant disclosures. Machine preservation has been utilized extensively for solid organ preservation such as kidney, liver, and lung, which has emerged as an alternative to static cold storage by expanding possible ischemia time. The success seen in solid organ preservation strategies encouraged research to also expand the boundaries of vascularized composite allografts imposed by ischemia time. Ex vivo normothermic lymphoperfusion allows sustained cellular metabolism throughout the preservation period, avoiding hypoxia and cold storage detrimental effects. To maintain cellular metabolism, the use of an oxygen carrier is necessary under normothermic conditions. Previous studies on ex vivo normothermic lymphoperfusion have shown promise in preserving limbs after amputation using red blood cells as oxygen carriers. Hemoglobin-based oxygen carrier 201, also known as Hemopure, is an ultra-purified polymerized bovine hemoglobin derivative with a hemoglobin concentration of 13 grams per deciliter, has a shelf life of 3 years, has no need for cross-matching, and is less viscous than red blood cells. This molecule has a high P50, which gives it a low affinity for oxygen, facilitating tissue oxygen extraction. This oxygen carrier has been used widely in clinical trials of kidney and liver machine preservation. Normothermic machine preservation is generally achieved using red blood cells as oxygen carrier, like I mentioned previously. The use of blood products is logistically challenging because of their short preservation time and need for cross-matching. Furthermore, human blood products are scarce and carry the risk of transmitting blood-borne pathogens. Therefore, we aimed to determine the feasibility of HBOC-based oxygen carrier 201 as a substitute for red blood cells during ex vivo normothermic lymphoperfusion. Under this aim, we tested the hypothesis that substituted red blood cells by HBOC 201 would exhibit comparable results for ex vivo normothermic perfusion. We procured 24 Yorkshire pig forelimbs, 6 undergoing ex vivo normothermic lymphoperfusion with HBOC, 6 with red blood cells, with an endpoint set up to 24 hours, and the contralateral limbs were used as static cold storage controls and were kept at 4 degrees Celsius. We report these results as means plus minus standard deviation. On average, we kept warm ischemia time between 22 to 44 minutes. Normothermic machine perfusion continued for 20 to 24 hours. We adjusted flow rates to maintain a mean arterial pressure between 70 to 120 millimeters of mercury. Flow rates averaged 340 plus minus 50 ml per minute in the HBOC 201 group and 470 plus minus 90 in the RBC group. Reports have been published on HBOC 201 vasoconstriction induced by this molecule. However, our results exhibited comparable results in vascular resistance between treatment groups. There were no significant differences in arterial and venous perfusion oxygen partial pressures nor oxygen saturation between groups. HBOC 201 and blood perfused limbs extracted oxygen at a rate of 2 ml per minute per milligram of tissue and 1.5 respectively. HBOC 201 limbs had the lowest oxygen uptake rate at time point 18, which coincided with the highest peak of methemoglobin. However, no significant correlation was found between methemoglobin concentrations and oxygen uptake rates. In both groups, lactic acid, sodium, and potassium increased throughout machine perfusion. Incremental changes in sodium transpired at a stable pace, whereas potassium increments were fluctuant and non-responsive to perfusitic changes. Percent weight change after 24 hours of perfusion was more prominent in the HBOC 201 group, with a mean difference of 5%. This translated into higher compartment pressures in the same group. This difference did not reach a statistical significance. Additionally, red blood cell limbs had more forceful contractions in the HBOC 201 group, but this also failed to reach a statistical significance. Myocyte injury counts at end perfusion confirmed a significantly higher number of necrotic myocytes in the cold storage control group at endpoint, but these were equivalent between treatment arms. Uninjured myocytes were also equivalent between both groups. Myocyte integrity remained intact after 24 hours of machine perfusion in both treatment groups. However, we identified hypoxic cell clusters defined as isolated cells with similarity to Senker's necrosis in the static cold storage controls at end perfusion. These cells were absent at 24 hours in both treatment groups. At perfusion endpoint, thermography and ICG angiography confirmed physiologic surface temperature and distal limb perfusion. In conclusion, utilization of HBOC 201 exhibits comparable results to red blood cell-based perfusates for ex vivo normothermic limb perfusion. HBOC 201 could potentially substitute the use of blood-based perfusates, overcoming logistical constraints imposed by these. I would like to thank my mentor, Dr. Bahar Basiri, for the opportunity of joining such a great team and for her guidance and mentorship. Also, I would like to send out a shout out to all the members of the Microsurgery Lab at Cleveland Clinic. Again, thank you for the opportunity of sharing our results with you, and I would now gladly address any concerns you may have.
Well, thank you, Dr. Figueroa. So now I would like to ask the two presenters, Dr. Figueroa and Dr. Ledwan, to please turn on their cameras. And we are opening up these two talks for questions. Please feel free to enter any questions you might have into the chat, and we will read those off.
So until we get some questions from the audience, I have a couple of questions. Dr. Figueroa, so you did this experiment with the limbs on the perfusion, but you did not re-implant the limbs following perfusion. Is that correct?
That's correct, sir.
So what do you think, is that part of the plan for the future? I mean, obviously ischemia reperfusion injury is going to be critical. I mean, there's a difference between these two perfusates. Obviously that's going to make a big difference in using it clinically. So what do you have any data on that that says that's not necessary, or is that something you're going to do in the future?
Yes, we're planning. We started a transplantation model using this molecule. So the surgeon amputates the limb, and while the surgeon is, we first procure the limb and then set it up in the machine perfusion. While the surgeon is making the amputation, we've perfused these limbs with this molecule. And yes, we've transplanted, I think, about 4 pigs. Yes, but we haven't published these data yet. So yes, it's in the future, in our future endeavors.
All right, fantastic. And then you mentioned that there was a possibility that this perfusate would increase the vascular resistance, but you really didn't see that. It looked like your data did show a slight increase in resistance and a slight decrease in flow. How do you know that's not significant from a hemodynamic standpoint?
So there's been reports of this molecule inducing vascular resistance, so vasoconstriction due to nitric oxide scavenging properties. There's some leakage of this molecule too in the endothelium. But we think that this increase in resistance occurs towards the end because of limb edema, which accumulates at 24 hours. So we think that it's, the limb starts to deteriorate around 18 hours, the final 18 to 24 hours, it starts to deteriorate. So we think it's more a cause of edema than the actual molecule.
All right, excellent.
Great. So Dr. Ledwan, so I'm a clinical researcher who's interested in translating lab findings to patients. And so we were wondering how you feel that your findings may impact human studies. Like, what is the next step?
Yes, of course. Thank you for this question. I will be happy to answer. So as I said in the presentation, we were able to discover these 2 microRNA highly dysregulated, up or down regulated in the porcine skin. But there's a high similarity between porcine and human skin. That's the first indicator that this data might be usable in humans. However, just like 2 weeks ago, our project was also funded by PSF. So we are starting functional analysis to better understand if this microRNAs regulate keratinocytes or maybe fibroblast biology. And obviously the last step will be to perform animal studies on animal model using mimic or inhibitor of this microRNA, and then to see how this treatment will influence tissue expansion outcomes.
So I find your study interesting because, relatively speaking, from a translational standpoint, this one, for me at least, to imagine the protocol that would be implemented is easier, even though it might, first occur in children. So pretty interesting. Look forward to watching that.
Thank you so much.
All right, we don't have anything in the chat. If anyone wants to ask a question with an open mic, we'd be open. If not, we're going to move on. All right. So next, I would like to introduce our next presenter, Alec B. Chang from Anne and Robert H. Lurie Children's Hospital of Chicago in Chicago, Illinois, who will be presenting the next paper, ACTA2 positive cells activation and dermal changes during skin adaptation to mechanical forces.
Good evening. My name is Alec Chang, and I'm a research technologist in the Gossain Lab at Lurie Children's Hospital of Chicago. Thank you for giving me the opportunity to present my research. I'm very excited to share the results of my work on ACTA2 positive cell activation and dermal changes during skin adaptation to mechanical forces. We have no disclosures. For our study, we used a porcine tissue expansion model, which is the best available animal model to study the molecular mechanisms in skin. Our experiments were designed to mimic the clinical use of tissue expansion in humans. Accordingly, tissue expanders were placed subcutaneously and were filled with a single 60 cc saline injection. One expander was placed on each side of the pig. Full thickness skin biopsies were collected from the apex of the expander to ensure that the tissue analyzed was under maximum tension. The biopsies were taken at 4 different time points: 1, 7, 14, and 21 days of expansion. Unexpanded skin from the same pig was used as control. Skin samples were preserved appropriately for downstream molecular and histological analysis. The goals of our study were to evaluate the safety of tissue expansion based on the role of activated ACTA2 positive cells, which are cells that express alpha smooth muscle actin, and based on molecular and morphological changes in the dermis during tissue expansion. We started our analysis from looking at the activation of the TGF-beta signaling pathway in fibroblasts, which are the most abundant cells in the dermis and are mechanosensitive. TGF-beta, together with integrins, are the primary biological pathways responding to mechanical forces in skin during tissue expansion. The key effector of the TGF-beta pathway is phosphorylated FAK, which we used as an indicator of TGF-beta pathway activation. After 1 day of expansion, immunofluorescence staining for phospho-FAK showed that in the expanded skin, more fibroblasts had nuclear localization of phospho-FAK. This result confirms activation of the TGF-beta pathway in the dermal layer of the skin under mechanical forces applied by the expander. The TGF-beta pathway contributes to skin growth and to the activation of myofibroblasts. Myofibroblasts are the main source of excessive collagen deposition, which might result in increased skin stiffness. We then analyzed ACTA2 expression, which is a marker of myofibroblasts and blood vessels. The Western blot showed increased expression of ACTA2 in expanded skin at 1, 7, and 14 days of expansion. To verify which cells, myofibroblasts or blood vessels, are associated with increased ACTA2 expression, we performed double staining with CD31. CD31 positive cells are an exclusive marker of endothelial cells, which are the cells that form blood vessels. ACTA2 is stained in green, CD31 is stained in red, and blue indicates nuclei. In this figure, the dotted white line indicates the epidermal-dermal junction, where below the line is the dermis. This staining showed co-localization of these two proteins, indicating that increased expression of ACTA2 during expansion is associated with changes in vascularization rather than myofibroblast activation. Increase in vascularization was also confirmed by the number of CD31 positive cells. We did not detect a significant increase of CD31 positive cells in skin after 1 day of expansion. However, we did detect a significant increase in the number of CD31 positive cells after 7 and 14 days of expansion. In agreement with these results, histological staining at later time points, 14 and 21 days, showed an increase in blood vessel-like structures and no changes in collagen deposition. We then ran a Western blot to analyze collagen 1 and 3 expression. Collagen 1 is the most abundant collagen fiber in the dermis, and collagen 3 is a protein essential for maintaining blood vessel integrity. The Western blot confirmed that there were no significant changes in expression of these proteins during expansion across all tested time points, 1, 7, 14, and 21 days. However, immunofluorescence staining revealed conformational changes in collagen 3, which again is an essential protein to maintain blood vessel integrity. We observed these changes in the papillary dermis right below the basement membrane of the epidermis. We concluded that tissue expansion is a safe procedure to stimulate skin growth because it does not activate myofibroblasts or excessive collagen deposition. Increased ACTA2 expression most likely reinforces blood vessels to help resist forces generated by the inflated expander, and that mechanical forces stimulate vascularization during tissue expansion as indicated by the increased number of CD31 cells in expanded skin, which is essential for tissue growth. Thank you to the rest of the Gossain Lab for your support and your help with this project. And thank you again for giving me the opportunity to present my work.
All right. Thank you, Mr. Chang, for that presentation. Our next paper is titled Correlation of Face Transplant Smile Excursion Measurements with Emotional Evaluation by Artificial Intelligence. And this will be presented by Nathan Hebel from Mayo Clinic in Rochester, Minnesota.
Hello, my name is Nathan Hebel. I am a medical student at the Mayo Clinic Alex School of Medicine, and I'll be presenting on the use of AI in our face transplant patient. So the authors have no disclosures, as well as all presented information has met IRB and HIPAA authorization. To begin with a brief overview, our team set out to assess the feasibility of using AI as a way to mitigate some of the telemedicine deficits we've learned about over the past year, as well as increasing the objectivity in surgical analysis, since historically it's been done by experts, which inherently has some subjectivity and bias to it. The way we did this is we wanted to compare the results of our AI with a software that did manual measurement of smile excursion to see whether or not there was validity there, as well as we did all this analysis on a normal cohort to see how our patient did over the 4 years relative to that group. So what we determined or discovered was that there was significant strength improvement as well as functional recovery, but there was some interesting patterns with the emotional results that we think is important and may lend itself to better or different contexts. Moving forward, we think that this program would be fantastic to use in Zoom. We know that it's capable, but that would be implementation for telemedicine would be fantastic, as well as comparison of different surgical techniques. So taking a deeper dive, what we did was we measured or analyzed our patient at 6-month intervals for 49 months. So the patient would come into the hospital, we would have videos taken of them doing different things such as puckering their lips or smiling, so on and so forth. And from those, we were able to analyze. So what we did was we'd take the clip of them doing a full face smile with teeth, run that through the face reader program, and they would output the values of the 7 cardinal emotions, as well as the key actioning and functionings. In figure 1 here, you can actually see a still frame of what the face reader program looks like when it's doing its live analysis. You can see the action units that are functioning overlaid on the mesh that is put on top of the face. And then also there are bars below the names of the action units showing the relative functioning from 0 to 5. And then that can be related to percentages, of course, with 1 out of 5 being 20%. And then the way that this is being able to be done is that the program was developed through 10,000 hand annotated images by experts. And so now it's able to track 500 key landmarks on the face, and that's how we get these different analyses. The facegram analysis was done on neutral repose and full face smile with teeth images. These are actually still images from the videos that we used on our face reader program. And then the smile excursion width was standardized based off of the iris diameter of the patient, just to ensure that there's consistency across all images. So what we discovered functionally was that our patient had fantastic results with respect to smile excursion. There was almost a near doubling. And the most exciting part was that this was actually very close to what the standard group smile excursion was, showing that there wasn't just improvement in strength, but almost a full recovery in strength for our patient. Now, the two action units that are key for improving smile excursion is the lip corner pillar action unit, as well as the cheek razor, which will elevate the lips. We did notice that there was a different pattern between our patient and the standard group, and that our patient had significantly more cheek razor action than lip corner pillar action. Now, there is a way to hypothesize the way that this is. There's a recent paper published that explained how different contexts, such as a natural smile or a posed smile or different emotions and such, how that will impact the way that our action units are functioning. So that might be the reason why that we have a different pattern here. And this also lends itself very well to the reason why our emotional results are different. So although we had a statistically significant increase from 0% to 10.6%, this is still much lower than the 51% of the standard group. And now, again, this has to do with the different context in which the patient is being filmed. So our patient was not perceived as being happy, and that's very clear if you look at the images. They weren't happy, they didn't look happy, and that shows how different action units in the face are going to significantly impact the perceived emotion of the patient. So although the program was fantastic for showing functional results and also for showing the emotion results, it needs to be looked at in the context of the whole patient, and also in cohort with the subjective analysis by an expert to see whether or not there are things impacting the results. So this is fantastic for showing proof of concept for the AI as a means to track the strength of a patient over time. This could be done in both transplant as well as surgical techniques such as facial rejuvenation or facial reanimation. But the emotional analysis, since it's impacted by so many different aspects of the face, may lend itself better to aesthetic surgery, especially full face aesthetic surgery such as facelift, since it's able to assess whether or not we're able to counteract some of those feelings that patients have of facial wearing or facial tiredness. And most importantly, or most interesting, this program could be used as a way to analyze different surgical techniques, such as different ways of doing facelifts, to see whether or not there are certain techniques with better emotion outcomes, different functional outcomes, different patterns, and tailoring the technique to the patient's goals or outcomes. So in conclusion, we had fantastic results for our patient, and that was reliably measured both manually and by the AI program, demonstrating that it is capable of tracking progression from a patient and between cohorts so that there can be comparison or longitudinal examination of a patient. As well, in the future, telemedicine implementation into programs such as Zoom or just analyzing videos of a patient will help reduce the need for patients having to come into the hospital. That's going to reduce patient burden, both infectious disease-wise and also financially. And then, as previously mentioned, this has fantastic avenues or opportunities for the use in aesthetic surgery, analyzing aesthetic surgery, as well as comparing different surgical techniques to ensure patients have the best outcomes. Thank you so much for listening.
Thank you, Dr. Habel. And next we have Graham Buchan from Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio. And he will be presenting the next paper, ICG Fluorescence Lymphography. Help me out.
Lymphography
after immediate lymphatic reconstruction.
Hi, my name is Graham Buchan. I'm a second-year medical student at Cleveland Clinic Lerner College of Medicine, and I've been working in the lab of Dr. Graham Schwarz in the Plastic and Reconstructive Surgery Department at the Cleveland Clinic. Today, I'm going to be talking to you about our research project investigating ICG fluorescence lymphographic patterns after immediate lymphatic reconstruction in the axilla. These are our disclosures. Breast cancer-related lymphedema is a major complication following treatment of breast cancer, particularly after axillary lymph node dissection. It affects an estimated 1 in 5 patients and imposes significant reduction in patients' quality of life due to medical, functional, aesthetic, and economic concerns. Breast cancer-related lymphedema is defined as the accumulation of protein-rich lymph fluid as a consequence of impaired lymphatic drainage that can cause severe swelling. Historically, treatment has been focused on decongestive therapy after diagnosis, but recent advancements in microsurgical techniques have been developed to both treat and prophylactically prevent breast cancer-related lymphedema. Lymphaticovenous bypass is a microsurgical technique that restores enterograde lymphatic drainage from the extremity the anastomoses of divided lymphatics with recipient veins. Example is shown here on the right. Prophylactic lymphaticovenous bypass performed at the time of axillary lymph node dissection, which can be referred to as immediate lymphatic reconstruction, has shown significant reduction in the development of lymphedema. However, questions persist over the long-term efficacy of immediate lymphatic reconstruction and the effect of post-mastectomy radiotherapy on lymphaticovenous bypass patency. Indocyan in green, ICG, fluorescence lymphography is an imaging technique used to assess lymphatic function and lymphedema status. Due to the dye's fluorescent properties when exposed to near-infrared light, ICG fluorescent imaging can be employed intraoperatively to identify lymph nodes and to assess lymphatic anatomy and function. Specifically, linear ICG flow patterns are consistent with functioning lymphatics, while dermal backflow patterns are suggestive of lymphatic dysfunction. In immediate lymphatic reconstruction, more specifically, it is used to visualize the baseline lymphatic function in the at-risk extremity, as well as to assess the patency of the lymphaticovenous bypass during surgery. Given the safety and the minimal invasiveness of ICG lymphography, it has been proposed that ICG studies could be used as a tool to assess changes in lymphatic function in patients who've undergone lymphatic reconstruction. But to our knowledge, the lymphographic outcomes of patients who've undergone lymphatic reconstruction remains a gap in the current literature. To that end, the aim of our study was to assess the lymphographic outcomes following axillary immediate lymphatic reconstruction in patients at high risk for breast cancer-related lymphedema. We hypothesized the ICG lymphographic studies in patients who've undergone immediate lymphatic reconstruction would demonstrate maintenance of linear lymphographic flow patterns throughout the upper extremity with linear transit into the axilla. We performed an analysis of a prospectively maintained database to evaluate patients with breast cancer who underwent axillary lymph node dissection and immediate lymphatic reconstruction with baseline intraoperative ICG lymphography of the at-risk extremity at our institution from September 2016 to November 2020. Baseline ICG studies were obtained during immediate lymphatic reconstruction, and repeat ICG studies were obtained during planned secondary stage breast reconstructive procedures. ICG studies were evaluated for lymphographic pattern as well as visualization of flow of the dye into the axilla, which is suggestive of sustained lymphaticovenous bypass patency. Baseline ICG lymphography studies were compared to repeat studies for each patient. Changes in lymphographic morphological pattern from baseline were noted and compared to current lymphedema status for each patient in order to determine the efficacy of repeat ICG lymphography in visualizing lymphedema. At the time of this analysis, 154 patients in our database had received immediate lymphatic reconstruction, of which 40 patients received baseline ICG lymphography in the OR. 15 of these patients had received repeat ICG lymphographic studies and composed our study sample. Average time from initial ICG to repeat study was 15.6 months. Average time from completion of adjuvant radiotherapy to repeat study was 11.3 months. All 15 patients in this study demonstrated brisk lymphatic transit in a linear pattern in intraoperative lymphography studies performed during the initial lymphatic reconstruction. Repeat lymphographic studies showed brisk, linear lymphatic transit in 12 of 15 patients, shown here in figure A on the right. Of these 12 patients, an average of 2.5 lymphaticovenous bypasses were performed, 10 received chemotherapy, and all 12 received post-mastectomy radiation. All of these patients remain lymphedema-free. Of these 12 patients, 7 postoperative studies demonstrated clear visualization of linear ICG flow from the lymphatics of the arm into the axilla without evidence of lymphatic collateralization. Example is shown here in figure B. An average of 3 lymphaticovenous bypasses were performed in this group, and all of these patients received adjuvant radiation. Lastly, dermal backflow patterns of varying severity were recorded in 3 of the 15 patients, 2 of whom showed signs of lymphedema prior to the repeat studies, and the last went on to develop clinically detectable lymphedema. An example of dermal backflow patterns are shown here in figure C on the right. Of these 3 patients, an average of 2 lymphaticovenous bypasses were performed, all received chemotherapy, and 2 of the 3 underwent post-mastectomy radiation. In conclusion, we demonstrated that ICG lymphography can be used as a postoperative tool to assess lymphatic function in patients who've undergone immediate lymphatic reconstruction. We also showed that repeat imaging studies in the majority of immediate lymphatic reconstruction patients demonstrated linear ICG flow similar to baseline. Lastly, ICG flow patterns with transit through the axilla and repeat imaging studies provided visual evidence suggesting sustained lymphaticovenous bypass patency despite inflammation and fibrosis associated with axillary radiation. With that, I want to thank you all for listening and invite any questions that you might have. Thank you very much.
All right. Thank you, Mr. Buchan. If the last three presenters would now turn on their cameras and unmute their microphones, while I'll open this up for questions. And we'll go ahead and do that one.
Let's see. So we have a question for Dr. Hubble. Sorry, Hable. Great efforts to provide objective measures for face transplant outcomes. Could you please elaborate on your PTOT and speech therapy protocols and how your post-operative measurements may reflect the gains seen clinically? And then, considering this potential correlation, do you think there is potential for functional standards to be set across patients to objectively define successful motor recovery in facial transplantation?
I think that's a fantastic question. I do have to say, I'm in my first year of medical school, so I'm not fully aware of all the protocols there. I would say that we are currently looking, like I said in the presentation, at the implementation with Zoom, and we're talking with rehabilitation on how we can kind of implement that clinically and see how we can assess longitudinally how patients are doing. I think functional standards, setting bars, there's potential there, but also I think people are going to progress at different rates and people are going to progress to different levels. And I don't think it's necessarily equivalent to say everyone's going to achieve full functional recovery because every case is so complex, especially in facial transplantation. I really like the idea, but I'm not sure how that would be implemented at this time.
And then has your group also compared this software in facial reanimation patients?
We have. I wasn't involved with that project, but I know that we have looked at it and we saw fantastic results there. We've looked at both functional surgeries as well as aesthetics. So we've done 15 facial rejuvenation patients, as well as like Botox, and then also facial reanimation. And we're trying to see what the ways this program can be used to kind of advance post-operative outcome analysis, just because, I mean, there are ways to analyze function as well as aesthetics, but we want to see if this is maybe a good way to mend the two, and if there are deficits in some or better applications in others. Like I said, we noticed in this project that although our patient had statistically significant emotion results, there was a lot of effect from the other parts of the face that we weren't examining, which showed that you can't just look at the program itself. It has to be done in cohort, probably with other forms of analysis, at least for this function-only patient.
And I actually have another question for you. I'm wondering if at the same time, perhaps the software already accommodates for this, but if you sent the images out, got opinions from like the lay public on the emotion, and then also if you assessed within the patient himself how he felt at each stage and how that compared with your AI.
I think that's a really good idea. Just speaking with our team, we know that to deem a surgery a success, it's probably from the patient's viewpoint. I mean, if they're happy with the aesthetic results or the function, that's probably the best measure. In one of our projects, we did look at how patients or observers perceived the images, such as like trustworthiness and honesty, things like that. We have not looked at specifically what you were saying, but I think it'd be interesting just to see how we could kind of expand the implementation of this, of the software, to see if there are maybe a wider net that we could cast so that it would be a little bit more of a smooth transition into implementing it clinically. Yeah.
And then Dr. Alfonso thanked you for your response and says, keep up the great work in quality research through medical school.
Thank you.
Dr. Buchan, I have a question about the lymphatic mapping that you did, was this part of a standard protocol that you then analyzed retrospectively, or was this a prospective trial to do this imaging specifically for this research study, or is this something that's part of the clinical protocol?
Yeah, so that's a great question. So I would say the initial kind of a baseline imaging study is fairly standard at our institution. There's some physicians who like to use like methylene blue, but it's become very standard as initial kind of baseline evaluation. The kind of secondary follow-up mapping that we've done during the planned secondary stage breast reconstruction, that was more designed for this study to see if we could see any changes in the postoperative period.
And so just make sure I understand your results properly. Were you trying to identify the function of the LVA by visualizing them, or just assessing the degree of lymphedema postoperatively? So is this a global assessment, or are you actually specifically looking for those LVAs?
Yeah, so I would say a little bit of both. This has been used, this is like a very common tool to assess lymphedema status. There hasn't been a lot of research into using this post immediate lymphatic reconstruction, so we wanted to gain just some information about what that looks like. And to your point on the second point about visualizing the LVA, one of the biggest criticisms launched against immediate lymphatic reconstruction is the potential of the LVA shutting down from fibrosis due to radiation therapy. And so one of the big goals of this was to see if we could visualize evidence of that sustained linear flow through the lymphaticovenous bypass.
All right. And it sounded like you had trouble finding the LVAs. You said you didn't see a anastomosis. Is that correct?
So out of the 12 patients who still had linear flow, we were able to see evidence of linear lymphatic flow into the axilla, which we take as a sustained patent LVA in about 7 of 12 of them. It doesn't necessarily mean that the other 5 have shut down. It's a little bit of a difficult area to visualize in the post-operative period because there's a lot of tissue. Lymphatics tend to go deeper into the tissue, making it a little bit more difficult to visualize, especially in patients with higher BMI. Yeah.
No, that's great. This is really interesting work, and it's very difficult to know how to quantify these things. And you look at these images when you take care of these patients, but having a framework and a way to quantify this is really important. So I encourage this work. So it looks like we have another question from the chat.
Yep. So this one is for Mr. Chang, and it's from Dr. Gassane. Could you let us know how vascularization changes during tissue expansion may demonstrate the efficacy of tissue recruitment during tissue expansion?
Yeah, thank you, Dr. Gassane, for your question. I would just like to start by saying that what we looked at was the number of endothelial cells, which are an indicator of vascularization, but we will have to have future studies that look at vascularization itself. What we did see was that there was no increase in vascularization after 1 and 3 days. However, after 7, 14, and 21 days, we did see what we think is increased vascularization, which just means that the tissue does have an adequate supply of blood, which obviously is needed for healthy tissue growth.
Yeah, and I have a follow-on question there. You talked about the other cell population there, the myofibroblasts, and said that you didn't see any evidence that these cells were activated based on the data you have. Did you look at proliferation though? I mean, it's specifically activation more important, or I know that in some of the other marker studies that showed cellular proliferation. So did you look at that, and how do you know these cells are really not responding to the expansion?
Yeah, that's an excellent question. we do look at proliferation, but in the dermis, there is just a smaller population of myofibroblasts. And what we saw more of was proliferation of fibroblast, less so myofibroblast. We know that they're not being activated because what we were seeing is increase in endothelial cells, which also do express the marker for myofibroblast. However, we are not seeing any additional activation of myofibroblasts that are just expressing the myofibroblast marker.
All right, we'll do another question from the chat here, and before we move on.
And so Dr. Oberoi has a question for Dr. Hebel. This is, let's see, was the software FaceGram software? Have there been any efforts to create a predictive model to project the expected outcome rates for patients as they are being tracked postoperatively?
I would have to say I'm not aware of any predictive models. I would say that through my personal use of the FaceGram software, I'd be more inclined to recommend the Face Reader artificial intelligence software. Although we did standardize based off of the iris diameter, the way that the program's set up is there's a bit of differentiation between different measurements and such. So what I did was I would have to take 7 or 8 measurements across each patient and then both sides of the smile and then average them. It was really time consuming relative to the artificial intelligence. We are looking at a predictive model for the artificial intelligence and seeing how that would function or work with our function results. The reason why we use the FaceGram software was more for external validity of the function results for our face transplantation. But beyond that, I'm not sure if there's much efficacy or utility in clinical use just due to the time constraint.
And then I have another question for you. You know, we've heard a lot recently about bias in AI models and how we need to be careful about that. Do you know what the fidelity of the AI is when looking at folks of differing skin tones?
I don't. The models or the groups of people that we have looked at, they are all Caucasian, so I'm not sure. I don't think we can speak from our own research on how it's been affected. And I'm not sure what the database that they used included. I know that it had the 10,000 images, but I'm not sure if that had varying skin tones or if it classified based off of skin tones and such. My apologies.
You know, it's important as if we move towards these artificial intelligence algorithms. It's very important to remember they're only as smart as the data you put in. Yeah. And if you take your cognitive bias into that, then you're going to program your machine learning algorithm with your cognitive bias or your predisposed idea. So just keep that in mind. Just because it's a computer doesn't mean it didn't learn all too well from our cultural biases along the way.
Yeah.
Absolutely. And if you'd like, I can put the North American rep for the company, the email in the chat. It's based out of the Netherlands, so if anyone wants to reach out with questions, they are more than willing to answer.
Thank you.
All right, fantastic.
We do have one more question. So we do, I believe, let me make sure. And this one goes back to Dr. Buchan. This is from Dr. Chang. How do you know the channel is the immediate repair? That could be a preserved flow because not all of the lymphatics from the arm develop lymphedema.
Yeah, so that's a fantastic question. And I think it is important not to overstate the evidence that we collected. I think the conclusion of our study is that the linear flow patterns that we're seeing just suggest that they could be the sustained patency of the lymphaticovenous bypass. I would say the thing I would say just in support of that is that because we do have both the pre and the post imaging studies, we're able to see kind of similar pathways and able to deduce that if they're following the same linear route, then it's likely passing through that lymphaticovenous bypass. And then the other thing I would say is that other groups who've been more interested in imaging studies, fluorescent imaging studies after dissection, and without a reconstruction have noticed collateralization and neovascularization, which is a bit more of a tortuous route, and the staining pattern, the visualization pattern is a little bit more diffuse. And so the fact that we didn't see that kind of pattern, again, lends support to the fact that lends support to the idea that it is going through the lymphaticovenous bypass. But that's a really good critique and something that we need to keep in mind when we're presenting this. Thank you.
Well, I think that's it for the questions that came through the chat. So gentlemen, you're out of the hot seat.
All right, I want to thank everyone for the very involved discussion. And I think that's the heart of PSRC, is actually getting into the weeds with some of these studies. I think that makes the science all that much better. We're going to be moving on now to our concurrent session. If you stay with us in this room, we're going to be hearing the quick shot presentations. And we're going to hear more science. And if you go into the breakout room, we're going to have a mentorship breakout room entitled Meet the Boss, Getting a Job, with the mentors David Mathis, Amy Moore, and Justin Sachs. And that's going to open up now. And I'll leave you and Carissa here, and I'm going to go and get it. No, I have a job. I guess I'll stay here and we'll do the quick shots. If you want to go to the breakout room, there should be a pop-up and just click join. We'll give you guys a few minutes. We'll watch the numbers, and once the numbers kind of stabilize after a minute or so, we'll get started on the quick shots.
Yes, and if you do not see a pop-up to join, you should see a breakout button at the bottom of your Zoom window, or 3 dots with the word more. If you click on that, you should choose breakout and you can join. And if not, you can send a private chat message to Pete LaCour and I can assign you. Thank you.
Pete, does that mean you can get us a job too?
Excuse me, say that again?
If you can assign us, does that mean you can get us a job too?
Absolutely.
All right, so we're pretty stable at 49 participants. Great. Next, I'm going to announce our first quick shot presenter, and this is going to be, let's see. I think something got deleted. Oh, there it is. Okay. Our first quick shot presentation is pre-implanted nerve grafts to improve functional outcomes in VCA, presented by Nick Von Giano from Johns Hopkins in Baltimore, Maryland.
I'm a postdoc in Sami Tafaha's Peripheral Nerve Lab at Hopkins. Tonight, I'm going to be talking about some of our work using pre-implanted nerve grafts to improve functional outcomes after limb transplants. So the big problem here is that proximal level limb transplants have poor functional outcomes. And we think that if we can lengthen severed recipient nerves prior to a transplant, we might be able to improve that. So we would use pre-implanted nerve grafts, where we would take those grafts, coapt them to severed recipient nerves in the amputated stump, furl up those grafts and leave them to regenerate for many months prior to a transplant. And then at the time of transplant, elevate those grafts from their wound bed, lay them down, and do more distal coaptation than would otherwise be possible. Previously, we showed using rat model that the process of elevating the grafts from their wound bed induces an injury to the number of myelinated axons. And now with this work, we want to have a look at what that mechanism of axonal injury is. And then we also want to introduce a pig model where we're having a look at the functional impact of those pre-implanted grafts. So firstly, in the rodent model, we took a sciatic tibial nerve isograft, reversed it, coapted it to transected median nerve, laid it down along the length of the forelimb, left it to regenerate for 8 weeks, at which point we biopsied the distal end, elevated the graft, laid it back down, waited a week, and then biopsied again. And Here we have a look at the axon counts, blue pre-elevation and then green post-elevation, and we saw that there was an increase in the number of unmyelinated axons after we elevated grafts, suggesting that there's demyelinating injury. And we thought this might be because of hypoxia in the distal ends of the grafts, because when we're elevating these grafts from their wound bed, we're separating them from the penetrating blood supply, such that the grafts are dependent on the axial or longitudinal supply from the proximal end. So we used laser Doppler to measure blood flow. The blue line here, where we first put the grafts in, which is effectively net zero blood flow. And then the red line after 8 weeks of regeneration, where there was robust flow. And then immediately after we elevated them, the blood flow in the distal graft in the gray line fell to net zero, such that in the distal half of the graft, there is a high likelihood of an ischemic injury. We now have a pig functional model where we're having a look at the impact of these grafts on functional recovery, where we take a pre-implanted nerve graft and then we do distal ulnar to median nerve transfer. And then in a control group, a proximal ulnar to median nerve transfer. And we developed a functional recovery test, which involves median nerve stimulation and hoof flexion, which we measure the force of over time. So in summary, this is a valid concept. We've got fiber axons after elevating, but that elevation causes demyelinating injury, likely due to hypoxia. And now we're using pigs to try and understand their functional impact.
Thank you, Dr. Banguero. Kevin Xu from University of Toronto, Ontario, Canada, will be presenting the next quick shot entitled Outcomes of Pediatric Dynamic Facial Reanimation After 2 Decades.
Thank you for the opportunity to present our research today on the outcomes of pediatric dynamic facial reanimation after 2 decades. My name is Kevin Zoe. I'm a plastic surgery resident at the University of Toronto, and we have no disclosures to make. Facial paralysis can result from both congenital and acquired etiologies. Without spontaneous recovery, there can be severe functional impacts on a patient due to their inability to smile. Today, the gold standard of treatment is free functioning muscle transfer to improve commissure excursion. However, the long-term outcomes of this procedure are not known, as these patients undergo this surgery very early on as children and are not necessarily followed into their adulthood. Our study objective was to evaluate the long-term surgical and patient-reported outcomes at least 20 years following dynamic facial reanimation in children. We performed a retrospective chart review, including patients with unilateral facial paralysis who underwent a 2-stage reconstruction with a cross-face nerve graft and free muscle transplant. Patients who were at least 20 years post-surgery were then contacted for enrollment. We performed non-parametric statistics to analyze our data. We used the FaceQ analysis software to measure our surgical outcomes with respect to commissure excursion at 3 time points: preoperative, early postoperative within 1 year, and long-term follow-up. For patient-reported outcomes, we used the FaceScale measurement of facial disability and impairment, as well as 2 subscales of the FaceQ. A total of 11 patients were included in this case series. At a median preoperative age of 7.3 years, the median commissure excursion was negative 1.3 millimeters. At the early postoperative time point within 1 year post-surgery, median commissure excursion increased statistically significantly to 7.0 millimeters. At the long-term follow-up of 23.7 years, median commissure excursion was 8.3 millimeters. There was no difference between median postoperative and median long-term follow-up commissure excursion. For patient-reported outcomes, low scores were actually rated for facial movement on the face scale, with eyebrow movement in particular being rated quite low. Despite this, there were high scores for facial comfort, oral function, as well as social function. On the FaceQ, the satisfaction with outcome scale demonstrated that 10 of 11 respondents definitely agree or somewhat agree with the statement, "I am pleased with the result." For the social function subscale, 8 of 11 respondents definitely agree or somewhat agree with the statement, "I feel confident when I walk into a room full of people I don't know." Here are some representative photos of our subjects. Limitations of our study included small sample size and retrospective design. In conclusion, dynamic reconstruction of unilateral facial paralysis in children improves commissure excursion that is maintained at long-term follow-up. As adults, patients have a high level of subjective satisfaction and social functioning. Further work is needed to improve movement of the lip and eyebrow. Thank you very much for your attention.
Right. Thank you, Dr. Zhu. Our next paper is The Ideal Match, Optimizing Partial Facial Transplants in Terms of Skin Tone Discrepancy. And this will be presented by Pooja Yazanthero from Johns Hopkins Medicine here in Baltimore.
Hello, everyone. My name is Pooja, and I'm an incoming plastic surgery resident at Stanford. I am so honored today to share our work from Johns Hopkins on skin tone matching in partial face transplants. The authors have no relevant disclosures. Partial face composite allotransplantation poses a unique aesthetic challenge in terms of skin tone matching, as the face is a highly important component of patients' overall sense of self, self-esteem, overall cosmesis, and social interactions. The degree of skin tone matching between graft and recipient that is considered acceptable, however, is not well understood. Thus, we investigated the degree of skin tone matching that is deemed aesthetically tolerable for partial face transplants based on recipients' gender and skin tone. We also wanted to see whether observer characteristics impacted their perceptions. We queried two populations, the general public and plastic surgeons. This was a cross-sectional investigation. Participants for the general public were recruited through Amazon MTurk, and surgeons were recruited through ACAPS. Participants were queried for aesthetic preferences using frontal face photos from age-standardized models, as shown in this figure. Skin tones of transplanted segments were varied using the Munsell color scale via Adobe Photoshop. We chose to simulate transplantation of the mouth and nose segment, as this is one of the most commonly transplanted areas of the face. In total, we recruited 550 lay participants and 21 plastic surgeons. On average, plastic surgeons tolerated a lesser degree of skin tone discordance than the lay public. 87% of lay participants versus only 33% of plastic surgeons believed that a change of 4 hues on the Munsell scale was acceptable, with a p-value of 0.02. Additionally, all survey respondents tolerated less of a degree of skin tone discrepancy on female faces when compared to male faces, only 2 hues difference tolerated versus 4 hues tolerated for males. Participants tended to tolerate less skin tone discrepancy in subjects with similar skin tones to their own, suggesting that people pick up more on differences when evaluating those with similar skin tones. In conclusion, our study highlighted the intensely subjective nature of aesthetic preferences surrounding skin tone matching on the face, which varied both by demographics and between surgeons and the lay public. Surgeons should ensure that they truly elicit their patients' preferences, especially given that our results demonstrated a greater tolerance for discrepancy amongst the lay public, as compared to plastic surgeons. Procuring a graft for facial allotransplantation is challenging. Understanding what level of skin tone discrepancy is tolerable to the recipient can help not only improve patient satisfaction, but can also lessen time to transplant by enlarging the potential donor pool. As always, the study was not without limitations. It was a cross-sectional investigation, and we had a limited surgeon sample size. Thank you so much to the Plastic Surgery Research Council for allowing us to present our work today. It's an incredible honor. I'd also like to take this moment to thank my mentor, Dr. Damon Cooney, as well as my study team. Thank you so much, and these are my references. Thank you.
So thank you, Dr. Yazanthero. Next, we have Fouad Baris-Bungur from the Department of Plastic Surgery, School of Medicine, University of Pittsburgh in Pittsburgh, Pennsylvania, who will be presenting Optimizing the Decellularization of the Rodent Epigastric Free Flap, a comparison of automated SDS-based protocols.
Thank you for the opportunity to present our study. My name is Boris Bengur, and I'm a postdoctoral research fellow at the University of Pittsburgh Department of Plastic Surgery. Complex wounds with exposed cortical structures usually require coverage with autologous free flaps. However, raising these flaps results in a donor site morbidity. One alternative strategy is using allogenic flaps, but their survival without rejection depends on the use of immunosuppressive agents. Tissue engineering research holds great promise to build replacement tissues without any morbidity to the patient. One of the first steps on creating engineered tissues is decellularization to remove the native cells. Perfusion decellularization has shown promise in whole organ engineering, yet there is minimal crossover into the microsurgical field. Sodium dodecyl sulfate-based protocols remain the predominant choice, but they are also known to have deleterious effects on the structure and capillary network of these scaffolds. Therefore, in this study, we aim to optimize SDS-based protocols for automated decellularization while maintaining a DNA content below the threshold and preserving the architecture of the free flaps. Rat epigastric free flaps were microsurgically harvested and cannulated. We used our custom 3D printed closed system bioreactor for the automated decellularization process. Flaps were connected to the bioreactor through their artery, and different STS perfusion times were compared with each other. We had groups with varying durations of STS perfusion as 3, 5, and 10 days. After STS, the protocol was consistent with Triton X100 for a day and PBS for another day. At the end, quantification of the DNA content was performed with picogreen. DNA contents in both skin and subcutaneous tissues were quantified separately. Overall, 5 and 10-day groups had the lowest total residual DNA content, while both being under the threshold level. The DNA content ratio of skin over the subcutaneous tissues was consistent with across all protocols, with skin having twice as much residual DNA after each protocol. For the structural integrity, while the 3 and 5-day groups were able to maintain their overall macrostructure, STS exposure for 10 days appeared to be too long. On further morphometric analysis, it was evident that 10-day group had damage to the structural integrity. The main pedicle vessels remained intact in all groups. The bioreactor is capable of decellularizing free flaps through an automated process. A protocol involving 5 days of STS exposure was the most successful to keep the DNA content at minimum while preserving the architecture. This compact and integrated system can decrease hands-on time and be used in the future for further recellularization of these scaffolds. Thank you.
All right. Thank you, Mr. Benkur. Now we're going to hear from Lauren Jacobson from Washington University School of Medicine in St. Louis, who will be presenting a wireless near-infrared spectroscopy device for flap monitoring, comparison to tissue oxygenation in a porcine musculocutaneous flap model.
Hello, my name is Lauren Jacobson, and I'm a PGY4 at Washington University in the Division of Plastic and Reconstructive Surgery. I'll be presenting my group's work on a wireless near-infrared spectroscopy device for flap monitoring, comparison to T-OX in a porcine musculocutaneous flap model. Drs. Pett, McEwen, and Rogers have intellectual property associated with the novel device presented here. Near-infrared spectroscopy, or NIRS, has gained favor for continuous, non-invasive monitoring of cutaneous free flaps. The T-OX device is a widely utilized NIRS monitor with excellent sensitivity and specificity for detection of flap compromise. It includes a cable connection between the probe and external display console. Unfortunately, shifts in patient position or attempts at ambulation can cause traction or twisting of the cable, resulting in spurious signal changes, necessitating immediate troubleshooting, undue worry for the surgeon and patient, and can even result in emergent unnecessary surgical exploration. Our group has developed a novel wireless near sensor capable of continuous cutaneous flap monitoring. In contrast to the T-OX system, this device utilizes Bluetooth technology to connect to a bedside iPad. This device, with its thin, flexible circuit board and silicone encapsulated structure, has a robust adhesive interface to enable continuous and wireless measurement of tissue oxygenation across flaps of various types and locations of the body, including across highly non-planar surfaces. An internal battery is capable of functioning for 5 days without recharging. With its diminutive size and weighing only 13 grams, this device can be worn comfortably without obstructing a large portion of the flap. Transmitted data from 2 flaps is logged, and measured STO2 is displayed in real time using a custom-developed app. The aim of the study was to determine if this novel wireless device is capable of detecting flap ischemia and congestion in a way that replicates the functionality of the wired Bioptics T-OX device in a porcine rectus abdominis myocutaneous flap model. After establishing a stable baseline, ischemia was induced by clamping the pedicle artery. After a 15-minute ischemic period, the flap was reperfused for 15 minutes before clamping the veins to establish venous congestion. This was maintained for 15 minutes before unclamping the vein and allowing flap reperfusion. The cycle of flap malperfusion and reperfusion was repeated twice more in each flap. This experiment has successfully been replicated in 3 separate animals. All results have been similar, and the results of our first experiment are shown here. Both devices produce similar tissue oxygenation tracings throughout vascular clamping events, with obvious changes occurring upon arterial clamping, arterial release, venous clamping, and venous release. In the study, we have presented a novel wireless NIRS probe for continuous monitoring of cutaneous free flaps. This device readily detects flap ischemia and congestion in a manner equivalent to the T-OX system in its porcine myocutaneous flap model. While conceptually similar to the T-OX device, our device utilizes self-contained LEDs and Bluetooth connectivity instead of a hardwired fiber optic connection, which we hope will make our device less susceptible to spurious signal changes caused by patient movement or wire traction. In future studies, the wireless NIRS device will be clinically tested in parallel with the T-OX device in human free tissue transfers. This will allow assessment of durability and longevity in the clinical environment and allow us to test the hypothesis that this novel device has equal capability to detect flat malperfusion with enhanced resistance to spurious readings and false alarms. Thank you for listening.
So thank you, Dr. Jacobson. Our next quick shot paper, Venous Thromboembolism After Deep Inferior Epigastric Perforator Flap Breast Reconstruction, Review of Outcomes After a Postoperative Prophylaxis Protocol, will be presented by Crystal Artuano from Division of Plastic and Reconstructive Surgery, University of Colorado, Anschutz Medical Campus in Aurora, Colorado.
Hi, my name is Crystal Tuano from the University of Colorado, and today I'm presenting venous thromboembolism after deep inferior epigastric perforator flap breast reconstruction, a review of outcomes after a postoperative prophylaxis protocol. I want to thank all of my mentors, as well as everybody that has assisted me in this presentation. Approximately 900,000 venous thromboembolism events, including DVT and PE, occur yearly in the United States. Breast cancer patients undergoing microsurgical breast reconstruction represent a relatively high-risk group for VTE events. However, an ideal perioperative dose of effective antithrombotic therapy that reduces the risk of VTE while minimizing the cumulative risk of bleeding is yet to be established. Surgeons often provide suboptimal doses of chemical prophylaxis, delay chemical prophylaxis initiation, or avoid it altogether in order to attempt to minimize postoperative bleeding. The Caprini risk assessment model has been found to be a valuable tool for VTE risk assessment amongst these patients who are undergoing autologous breast reconstruction. The study is a single institution review on the rates of VTE following implementation of a postoperative VTE prophylaxis regimen. A new chemoprophylaxis protocol was introduced starting March of 2019 that involved 2 weeks of treatment with enoxaparin, regardless of patient risk factors. A retrospective chart review was then conducted on all patients who underwent deep flap breast reconstruction at our institution between January of 2014 and March of 2020. Patient demographics, prophylaxis type, and outcomes data were recorded retrospectively. The primary outcome measure was postoperative VTE incidence. Categorical variables were analyzed with a chi-square test and continuous variables with a student's t-test. A total of 265 patients underwent deep flap breast reconstruction. 63 patients were discharged with VTE prophylaxis and 202 were discharged without. Patient characteristics were found to be similar between the patients before and after the protocol. A total of 9 patients, or 3.4%, were identified, all of which were in the group prior to implementation of a protocol. This is a visual representing this and some of the patient characteristics in this population that we studied. 174 patients had bilateral reconstruction and 91 had unilateral reconstruction. 3 patients had a DVT, 5 had a PE, and unfortunately, 1 patient had a DVT and a PE. All of the VTE events occurred within 30 days of the original surgery date. Overall, 67 patients were taken back to the operating room, 22 were in the protocol group, and 45 were not in the protocol group. In conclusion, this retrospective study demonstrates successful implementation of a 2-week fixed-dose chemoprophylaxis regimen for patients undergoing deep flap breast reconstruction. The number of VTE events that occurred are comparable to studies at other institutions. Additional analysis of patient characteristics with VTE at our institution can lead to establishment of a local protocol with individually tailored prophylaxis regimens. Furthermore, this can be improved by adding prospective risk assessment, inclusion of the Caprini RAM, and patient anti-10A levels in our institution's deep flap database. These are my references. Thank you very much and have a great day.
Nice.
All right, thank you, Dr. Tuano. Next, we have Marion Guttard from Harvard Medical School in Boston, Massachusetts, and Massachusetts General Hospital, who will be presenting the effect of static cold storage on vascularized composite allografts.
Hi, I will present a study on the effects of static cold storage on vascularized composite allografts. The current gold standard in organ preservation is static cold storage. However, with this method, human VCA's ex vivo preservation is maxed at 6 to 8 hours, after which tissue injuries eventually lead to higher risks of graft failure. This limited storage time hinders the possibilities of vascularized composite allotransplantation. In order to set the ground for other preservation methods like ex vivo perfusion studies in VCA, we aim to determine the time limits of static cold storage for rat VCAs. We harvested partial hind limbs from Lewis rats that were then subjected to cold storage with HTK solution. Those limbs were then heterotopically transplanted in a syngeneic Lewis rat using a surgical model we developed. The animal was followed up for 3 weeks post-transplantation, and the survival of the VCA was assessed at postoperative day 21 by the positive patency test of both femoral vessels. After 12, 18, and 24 hours of cold storage, we observe an increase in early postoperative complications without reaching statistical significance in the survival rate. However, after 48 hours of static cold storage, the VCA survival dropped significantly at postoperative day 21, indicating a delayed graft failure. This shows normal evolution in a non-ischemic transplant, with total hair regrowth after 2 weeks and good healing by postoperative day 21. After 12 hours of static cold storage, a very limited epidermolysis appears on the graft at the end of the first postoperative week, and as durations of cold storage increase, we observe larger areas of epidermolysis, leaving scarring tissue on the VCA after a day of static cold storage. But even for a graft that has been cold stored for 48 hours, we can observe a good clinical evolution of the VCA. However, in this group, the clinical evolution did not predict graft failure. Only when opening up the VCA, we noticed deep muscle necrosis and patent artery but a flat vein. This suggests that rat VCA skin can easily heal with contiguous vascularization and that delayed graft failure cannot be clinically diagnosed, at least in the early stages. Most studies start at the rodent scale. Our study sets the basis for the standard time limit in preservation studies on rat VCA. We can consider that they can tolerate up to 24 hours of cold ischemia without significantly impacting the survival rate in the transplantation model, which represents 4 times the allowed ischemia time in human VCAs. Our next step will be to optimize graft preservation and storage durations using ex vivo perfusion and scale up to large animal models. Thank you for your attention.
Thank you, Dr. Guittard. Next, we have Mimi Rosalie Borelli from Brown in Providence, Rhode Island, who will be presenting fat grafting depletes profibrotic PRRX1 positive fibroblasts in irradiated skin and mitigates radiation-induced groin contracture.
Hello, and thank you for the opportunity to present. I have nothing to disclose. Almost 2 million individuals in the United States are diagnosed with cancer every year, and roughly 2/3 of patients will undergo radiation therapy. While extremely effective at shrinking tumor size and reducing local recurrence rates, radiation therapy can lead to significant contracture deformities and functional impairment. Fibroblasts are the principal cell of the dermis and are primarily responsible for collagen deposition. Recent work has highlighted that dermal fibroblasts are extremely heterogeneous, comprised of multiple subpopulations. My work in the lab has shown that using a double transgenic mouse, where fibroblasts that express PRX1 are labeled green and PRX1 negative fibroblasts are labeled red, that the PRX1 positive green fibroblasts are responsible for the majority of collagen deposition and scarring in the mouse ventral dermis. Fat grafting is a surgical technique being increasingly recognized for its regenerative and anti-fibrotic effects. And therefore, in this work, I asked whether fat grafting could reduce radiation-induced groin contracture, as well as alter the composition of PRX1 positive fibroblasts in the mouse ventral dermis. In order to use my transgenic PRX1 positive mouse, I first needed to reconstitute the bone marrow. I subjected mice to whole body lethal irradiation and immediately reconstituted them with 2 million nucleated bone marrow cells derived from donor NSG mice. I used flow cytometry to show successful immunodepletion and engraftment 3 weeks after bone marrow transplantation. I then irradiated the right hind limbs of all the mice with 30 gray over 12 days and allowed a 5-week recovery period during which the mice developed significant hind limb contracture, as shown by this picture and graph measuring limb extensibility. Histologically, the skin of the irradiated hind limb was thicker and had a substantial expansion of the PRX1 positive fibroblast subpopulation. Next, I derived samples of fresh human lipoaspirate and injected half of the irradiated limbs with 200 microliters of fat and measured limb extension over 8 to 12 weeks and looked at the effects on fibroblast subpopulations by FACS and histology. I used computed tomography imaging to show there was minimal resorption of the fat over the 8-week investigation period. And then I showed by histology, in fact, that there was a significant decrease in the number of profibrotic fibroblast subpopulations in the grafted mice compared to the non-grafted irradiated limbs, and this was associated with significant improvements in limb extension. So in conclusion, fat grafting improves the extensibility of irradiated and contracted limbs and reverses radiation-induced skin fibrosis by depleting profibrotic fibroblast subpopulations.
Thank you, Dr. Borelli. The final paper in this quick shot session is Morphological Changes of Skin Related to Acellular Dermal Matrix Incorporation in Tissue Expansion, and this will be presented by Sarah Applebaum from Northwestern University in Chicago, Illinois.
Hello, my name is Sarah Applebaum, and I'm grateful to present our work on the morphological changes of skin related to acellular dermal matrix incorporation and subacute tissue expansion. Our work was funded by the PSF MTF Biologics Allograft Tissue Research Grant. Acellular dermal matrix, or ADM, is a human-derived connective tissue graft that consists of preserved extracellular matrix. Previous work has demonstrated an improved aesthetic outcome with the use of ADM and two-stage tissue expander reconstruction. However, the safety and efficacy of ADM remains controversial. In our study, we designed a porcine model of prepectoral tissue expansion to evaluate the role of ADM in skin growth stimulated by mechanical forces. Our goal is to improve skin quality in women undergoing tissue expansion and post-mastectomy radiation therapy. First, pigs underwent tattooing and placement of subcutaneous tissue expanders. Half of the tissue expanders were wrapped in a contoured sheet of ADM and secured using non-absorbable sutures. Next, we performed 2 weekly inflations. 1 week after the final inflation, a subset of pigs received a single fraction of 20 gray radiation, which is equivalent to the most commonly used dose in breast cancer. Tissue was harvested at 2 different time points, before radiation and 2 months after radiation. At both time points, 3D photos and skin biopsies from the apex of the expander were preserved for downstream analysis. Trichrome staining was performed to visualize histology and measure collagen fiber orientation. We identified successful incorporation of ADM as indicated by the presence of cells invading the ADM. In comparison to control skin, the orientation of collagen fibers in tissue expansion alone, or TE, underwent greater change than the collagen fibers in TE plus ADM. To determine the effect of ADM on cell turnover, we performed qRT-PCR to measure gene expression levels of BAX, a pro-apoptotic gene. In doing so, we identified higher levels of BAX in TE than in TE plus ADM. Lastly, we conducted isogeometric analysis to estimate skin growth and stretch over multiple time points. In the presence of ADM, our results showed continued growth of expanded skin 2 months after radiation. In the absence of ADM, however, irradiated skin did not demonstrate growth at the 2-month mark. Moreover, the pattern of skin growth after radiation in TE plus ADM most resembled skin growth patterns in non-radiated skin. Overall, ADM was found to successfully incorporate with nearby tissue and prevent some of the architectural changes in collagen disarray typically observed during tissue expansion. Furthermore, the presence of ADM induced lower levels of BAX, thereby leading to continued skin growth despite radiation-induced injury. Thank you.
All right, very interesting study. Thank you, Dr. Applebaum, and to all of our quick shot presenters. That was drinking from the fire hose, scientifically speaking. I think we should, at this point, have everyone, it looks like we're on time, so we should have everyone back from the breakout room. And it looks like our numbers reflect that. So I would now like to move on to the next phase of our presentation this evening and introduce our invited speaker, Dr. Ed Chang, who will be speaking on a topic that I think everyone has been thinking about this whole year and something that's very topical, and that is microvascular free tissue transfer and the effects of the recent COVID-19 pandemic on the flaps and on our patients and on our practice. So I'm excited to hear this talk. Dr. Edward Chang is the Associate Professor in the Department of Plastic Surgery at the University of Texas, MD Anderson Cancer Center, graduated summa cum laude from the University of Pennsylvania, and then graduated AOA with honors from NYU. Following that, he completed a combined plastic surgery residency at the University of California, San Francisco, including 2 years at Stanford, researching stem cells in diabetes and aging, before going on and doing a microsurgery fellowship at MD Anderson Cancer Center, where he still is now. He's published over 120 peer-reviewed articles on basic science and clinical outcomes and specializes in microvascular free flap reconstruction for breast, head and neck, and extremity defects, as well as super microsurgery for lymphedema. And like I say, I look forward to hearing what he has to say about microsurgery during COVID-19.
Greetings. I thank the Plastic Surgery Research Council for giving me the opportunity to present our experience with microvascular free tissue transfer during the times of the pandemic. Here are some of my disclosures. As a brief outline for this talk, we're going to go into some of the background experience with free tissue transfer at our institution, and then we'll go into some of the changes and trends in the surgical volume at our institution, followed by some specific case examples of complications that occurred during and previous to the pandemic. So again, at most high volume institutions, the success rate for performing microvascular free tissue transfer is quite high. In general, over 95% in most high volume institutions. At our institution, when we looked at our experience with multiple different types of free tissue transfer for head and neck, breast, extremity, as well as pediatric reconstruction, we found that our success rates were actually quite good, and many of the previously presumed risk factors and relative contraindications for performing free tissue transfer really did not seem to be statistically significant risk factors that would preclude patients from undergoing such an operation. Unfortunately, with the pandemic, a number of things came to a head that really could impact the success rate, or at least the volume of reconstruction performed at many institutions, including ours. When we see the trends in the hospital case volume, we do find that there was a statistically significant decline in number of cases that were being performed. This again was secondary to a lot of different factors. In one regard, from a free tissue transfer perspective, we're very worried about hypercoagulable conditions, and there are many case reports of patients who have been infected with the coronavirus who suffered a stroke or a cerebral vascular event in a relatively otherwise healthy patient, suggesting there may be a hypercoagulopathy that is associated with the coronavirus infection. Aside from the physiological changes in the respiratory as well as the cardiovascular systems in patients that are affected with the coronavirus, there were logistical restrictions that were placed on hospital volumes. So when we look at the trend at our institution at the onset and the beginning of the pandemic, we did not see many changes in the volume initially when the first cases were being reported. It was not until the pandemic became a state of national emergency with recommendations from the Surgeon General and restrictions placed both on the national as well as the state level that we really witnessed a decline in the number of cases that were being performed at our institution. And again, the rationale for this is logical because it was designed to preserve resources, hospital beds, ICU beds, protective equipment in order to be able to treat patients that were going to become infected with the coronavirus. When we look at this on a more granular level and we look at the case volume on a week-to-week basis, again, we did not see much changes in the volume initially. The decline here obviously coincides with the holiday time period where typically the case volume is always slightly lower than around the baseline numbers. However, this was around the time where the first case was actually reported in Wuhan, China. During the early phases of the pandemic, where the initial cases were first being described, again, we did not see a statistically significant change in the actual volume of cases that were being performed. It was not until March where restrictions were put in place because of the obvious increasing fear and recognition about the impact of the coronavirus that we really saw a statistically significant decline in the case volume at our institution. So again, in blue is the time of the pandemic in 2020, and in red is the number of cases per 2019, and obviously we see again in March there is a statistically significant decrease in the number of cases that were being performed. When we looked at this in greater detail and we broke down the number of cases that were performed by each individual division, subspecialty, and department or institution, we saw a global decrease in the number of cases that were being performed. So in every subspecialty, we saw a decline in the total number of cases that were being performed during the time of the pandemic. And again, plastic surgery was no different, especially when there were restrictions placed on performing elective cases. Many of these cases where we're performing breast reconstruction, either it be implant-based or autologous,
or revisions for these patients, the number of cases were obviously restricted and we could not perform these elective operations during the pandemic. So again, we saw a statistically significant decline in the number of cases that were being performed. When we looked specifically at microvascular free tissue transfer, we saw a subtle decrease in the number of cases that were being performed. In 2019, we had 708 patients undergo a free flap. In 2020, there was a decline, this number to 654 patients. Now, this is actual patients, not the total number of free flaps performed. The total number of free flaps performed is obviously going to be considerably larger than this because we have patients undergoing bilateral breast reconstruction or undergoing multiple flaps, stacked flaps in order to reconstruct the breast. And for many of our head and neck cancer patients who had more extensive disease, many of these patients unfortunately needed multiple free flaps in order to reconstruct the defect. But when you look at the actual number of patients that underwent a microvascular free flap, we saw a subtle decline in the number of patients that were getting a free flap. This again is very difficult to attribute to whether or not it was secondary to the pandemic or whether it was due to other issues. However, this decline in number is very difficult to determine whether or not this is a statistically significant decline from the baseline number of patients that we were treating. When we looked at the specific type of patients that were undergoing reconstruction, again, not much of a difference. There was a subtle decrease in numbers, but again, very clearly not very much different from 2019 to 2020, where 169 patients underwent an autologous breast reconstruction compared to 164 patients during the time of the pandemic. What happened for us during the pandemic was after the restriction on elective breast cases and elective breast reconstruction was lifted, many of the patients that were put on hold were able to get back onto the schedule in order to reconstruct their breasts in the later half of 2020 when the restrictions were lifted. So microvascular breast reconstruction in our institution is generally a fairly successful operation. When we looked at our experience over a 10-year time frame, we found that our success rate was 97, 98%, so very highly successful regardless of many of the relative contraindications such as previous radiation, smoking, diabetes, obesity. None of these factors were really predictive of suffering a flap loss or requiring a return to the operating room for salvage of a flap. The factors that were statistically significant for flap loss were really technical issues in the flap design and the type of flap that was being performed in order to reconstruct the breast. So again, what we found during the pandemic was there was a subtle decrease in the number of patients undergoing autologous reconstruction. And again, this was likely secondary to the restrictions that were placed on performing elective operations. But the number of patients and likely the actual number of free flaps performed were not really different from 2019 to 2020. When we looked at the patients that actually suffered a microvascular complication, again, very difficult to determine whether or not this was secondary to the pandemic coronavirus or whether this is just the expected baseline of complication that we would anticipate because there was not a dramatic difference from 2019 to 2020. In 2019, we had 2 patients that required an unplanned take-back for salvage of a flap, and while there were no flap losses in 2019, we only had 1 flap loss in 2020. So this is a case of one of the patients that required a unplanned return to the operating room for compromised perfusion in 2019. I previously treated her for a recurrent right breast cancer. She underwent a partial mastectomy with adjuvant radiation and unfortunately has developed recurrent disease. So she underwent a completion mastectomy and we reconstructed her with a free deep flap. Then, unfortunately, she developed a left-sided breast cancer and underwent a skin-sparing mastectomy and reconstruction using an expander implant approach. Over time, unfortunately, she became less pleased with the implant-based reconstruction, which again is very common as we've seen from many studies that have previously demonstrated a decline in satisfaction with implant-based reconstruction over time. So she wanted to have the implant reconstruction exchanged out for autologous tissue. So we took the patient back, this was in 2019, and removed the implant and exchanged her for bilateral stacked pap flaps. This again was performed in a stacked orientation using the antegrade and retrograde internal mammary vessels. There were no complications with the anastomosis. We typically place the retrograde perfused flap in the superior pole because we tend to crisscross the pedicles. And unfortunately, the patient had kinking of the pedicle that went into the superior pole. We lost the implantable Doppler signal and had to take the patient back in order to reposition the flap, and the flap was successfully salvaged without difficulty. So again, while this was a complication that occurred in 2019, this could have occurred at any point in time and could not obviously be attributed
to the issues of the pandemic or the coronavirus. The other patient who unfortunately lost a flap entirely during the pandemic was also a thigh-based flap with one of my colleagues, again, performing a stacked orientation, and it was a stacked tug and pat flap, and unfortunately the tug flap was lost. A recent flap complication that occurred in 2021, not during 2020, was an issue of a bipedicle flap. So again, we've demonstrated very high success rates performing a bipedicle deep flap in order to reconstruct a unilateral breast defect. In this operation, you're taking the entire abdominal tissue, both deep infragastric pedicles, and performing double anastomoses, again to the antegrade, retrograde, internal mammary vessels, in order to perfuse the entire abdominal tissue to provide enough volume to reconstruct the breast. So this is a young lady who unfortunately has a right-sided breast cancer. She has relatively large breasts in relation to her abdominal tissue, so we needed to harvest her entire abdominal tissue and perform a bipedicle flap, harvesting both the deep infragastric vessels in order to reconstruct her breast, and we're able to achieve a reasonably symmetric, balanced reconstruction for her. This is another patient who again had a very aggressive right-sided breast cancer for which she underwent a modified radical mastectomy, and again presented to us for reconstruction postoperatively and required the entire abdominal tissue in order to reconstruct the breast to match the symmetry and volume of the contralateral breast. Again, we performed the anastomoses in a antegrade retrograde fashion. Again, we tend to crisscross the vessels. Whether or not you want to crisscross it or perform it in line is a very surgeon dependent issue. But again, not a clear issue with the anastomoses. In her case, no issues, and she has a very reasonable reconstruction postoperatively. One of these bipedicle flaps performed by one of my colleagues, unfortunately, they lost half of the bipedicle flap, or unfortunately, they suffered a complication which with the, I believe, the retrograde internal mammary system, and unfortunately, they lost half of the flap. This again, though, however, occurred outside of the pandemic period, and this occurred in 2021. So again, it seems that while there are some complications associated with breast reconstruction, these could be complications that would have occurred regardless of the impact of the coronavirus. When we look at head and neck reconstruction, again, when we look at it in more granularity, this is not obviously significantly different from our previous experience. In our institution, head and neck reconstruction can be performed at very high success rates ranging from 97 to 98%. Again, when we looked at it in greater detail, in 2019, we had 10 patients that required an unplanned return to the operating room. 2 of them were for a hematoma, so only 8 of them were for compromised perfusion, 4 for venous congestion, and the other half for a loss of the Doppler signal or a change in the clinical exam. Of these 8 patients who had compromised perfusion, there was 1 total flap loss in 2019. When we look at 2020, there was a slightly higher number of patients that required a return to the operating room for compromised perfusion, 12 patients instead of 8 patients. And again, in greater detail, we find that 9 of these patients were secondary to venous congestion. 3 of these patients were due to change in clinical exam and only 1 for a hematoma. And during 2020, we had 4 total flap losses. So again, this is slightly higher in 2020 than 2019, but whether or not this could be directly attributable to the coronavirus is very difficult to say. This is one of the patients, unfortunately, of mine that did suffer a total flap loss during the 2020 pandemic. She underwent her previous reconstruction with us years ago. She had a previous radial forearm flap for a partial glossectomy defect that was performed at another institution. When she developed recurrent disease in her maxilla, she underwent a right total maxillectomy, and we reconstructed her with a chimeric scapula Tdap flap. She had no issues with this flap, underwent a very uncomplicated recovery course, but again, unfortunately, developed recurrence during the pandemic. She was taken back for a very extensive resection. Here you actually see the skin paddle of her Tdap flap. However, they removed the previously done radial forearm free flap and had a near hemiglossectomy defect. She also had a mandibulectomy defect for the recurrent disease, so we needed to perform 2 free flaps in order to reconstruct the mandible defect as well as the tongue defect. Unfortunately, because of the prior radiation and the surgery, we also had difficulty closing the neck, so she needed a 3rd free flap for neck resurfacing. So here's a free fibula flap for the mandible. We harvest a medial artery perforator flap in order to reconstruct the tongue, and an ALT flap for the neck resurfacing. Unfortunately, on postoperative
Day number 1, she developed a issue with venous congestion, the MSAP flap, and we took her back, and unfortunately we were not able to salvage it, so we needed to perform a radial forearm-free flap from her other arm in order to reconstruct the glossectomy defect, and she overall went on to heal very well. Unfortunately, her cosmetic appearance is somewhat compromised, and we recently just took her back in order to revise her cosmetic reconstruction. But again, this was a flap loss that occurred during the pandemic, and whether or not this could be attributed to the pandemic itself is very difficult to surmised. However, when we look at the specific issue of delayed flap loss, this was an interesting finding that, again, very difficult to treat the coronavirus, but an interesting finding nonetheless. When we looked at our previous experience over a 15-year time frame, we found that 17 patients developed a flap loss after they were discharged from the hospital. 10 were breast flaps, 7 were head and neck flaps. This was one of the patients that was included in the study, a young gentleman who had a very aggressive tongue cancer who underwent a subtotal glossectomy. We reconstructed him with a free ALT flap. The patient was discharged without difficulty, no complications, but unfortunately presented approximately 2 weeks postoperatively with a significant coughing episode. And unfortunately, he avulsed his pedicle that it was not salvageable. And unfortunately, we had to reconstruct him with a pedicle pectoralis myocutaneous flap. When we look at the pandemic timeframe, we did have more delayed flap failures, 3 in fact. Unfortunately, 2 of those were my patients. This is a young gentleman who unfortunately had previous radiation, who has developed osteoradionecrosis, significant trismus, no recurrent cancer. He was taken back for a posterior mandibulectomy, partial pharyngectomy, and we reconstructed the patient with a free profound artery perforator flap and harvested a chimeric adductor magnus flap for additional soft tissue fill in the neck and to minimize the risk of a fistula. The patient was discharged without difficulty, but unfortunately presented back nearly 3 weeks after his initial operation with total loss of the PAP flap. We had to take him back and needed to perform a second flap, a free ALT chimeric flap with the vastus lateralis in order to reconstruct his posterior mandibulectomy defect. So again, this was a delayed flap loss, very difficult to surmise why he lost the initial PAP flap. And again, whether or not this could be attributed to the coronavirus is difficult to say. This again is another one of our delayed flap loss patients, and again, a very tragic situation. A patient who has developed recurrent laryngeal cancer following previous radiation and chemotherapy that we took to the operating room and reconstructed her total laryngopharyngectomy defect with a free tubed ALT flap. We again harvested some vastus lateralis in order to buttress the repair and also to serve as a monitoring segment. The patient did well, no issues with her postoperative hospital course. She presents nearly 2 months postoperatively, had passed her modified barium swallow study, and unfortunately, we found to have LT flap, unfortunately, was not viable. So we had to reconstruct her with a free jejunal flap. And again, unfortunately, she needed a second free ALT flap in order to resurface the neck. So this is her on the table, the free jejunal flap. They had to remove the first rib and the clavicle, so we performed a pectoralis muscle flap in order to cover up the lung, and again the ALT flap in order to resurface the neck. And postoperatively, she did fine, no issues. She underwent a modified barium swallow, which did not demonstrate any evidence of a leak or a fistula, and a viable ALT and free jejunal flap. So again, compared to our previous experience of 7 head and neck flap losses in 15 years, we had 3 delayed flap losses during this time frame. One was from a colleague of mine who had an ALT for a laryngectomy defect, total flap loss on postoperative day 19, and then the 2 cases that I showed previously with the posterior mandible and another laryngopharyngectomy defect that presented with total flap loss after their discharge. And finally, just to sum up our experience with pediatric free flaps, again, these are predominantly for head and neck reconstruction, which again, we've shown to have very high success rates. In the pediatric population, the success rate was greater than 95%. And again, this is an operation that can be performed very reliably in younger patients. This is one of the patients that was included again in the previous study, a patient of mine, a young 3-year-old boy who unfortunately has an embryonal rhabdomyosarcoma, was taken to the operating room for an orbital exoneration that we performed a free ALT myocutaneous flap for. Unfortunately, he lost the ALT flap, and we had to perform a second ALT flap in order to reconstruct his orbital exoneration defect. During the time of the pandemic, we still had to treat pediatric patients who perform microvascular free flaps for reconstruction of their defects. This is a young
lady who unfortunately has a parotid sarcoma, skull-based sarcoma, who underwent a fairly extensive resection after radiation that we reconstructed with a free chimeric ALT vastus lateralis flap in order to resurface and provide additional coverage of the skull base. And she underwent the reconstruction with a non-complicated hospital course and is actually going to be scheduled for revision surgery in order to optimize her cosmetic results. This is another young patient who again has a sarcoma of the left parotid gland, who underwent a total parotidectomy with facial nerve preservation that again we reconstructed with a free chimeric ALT flap. And then this is her postoperatively following adjuvant radiation with a healthy viable flap and no evidence for a total flap loss. So again, overall, while we did see a subtle decline in the number of patients who had a free tissue transfer performed during the times of the pandemic, there may have been a subtle increase in complications, but this again does not seem to be statistically significant compared to our previous experience, nor could it be directly attributable to the coronavirus itself. Again, our overall success rates are still quite high and are very comparable to our historic success rates. Some of the more interesting findings were these findings of delayed flap loss and whether or not this is secondary to the pandemic certainly warrants further research and further analysis. But again, because of such low numbers, it's very difficult to ascertain and perform more rigorous analysis for these complicated patients. Thank you again for the opportunity to present our research. And again, I'd like to thank our fellows this year who have been very diligent in working through the pandemic and have been taking care of our patients, and some of the other inspiring mentors that I've had throughout the years. Thank you so much for your attention.
All right, thank you. That was a fantastic talk and a tour de force of microsurgery, as always, as to be expected from the Andy Anderson crew. We invite any questions from the audience about that while we're waiting to see if anything comes in the chat. I just want to say, you know, it was really interesting to look at the numbers, how you guys shut down and then sort of made up. It sounds like, but your overall numbers were the same for the year, which means you must have sort of overcompensated in the second half of the year. And I just want to contrast that with what our experience here is. We had that same shutdown. It looked like the timeline was about the same as you guys, but we had a lot of concern from hospital leadership about turning the machinery back on, and we had a very long reactivation phase and a lot of and you know, to be careful and everything else, but we had a lot of milestones and hoops to go through and check boxes to check before we were allowed to restart our reconstructive surgery, especially elective like breast reconstruction. That can be delayed. We didn't see that as much in head and neck, but our breast reconstruction this year is not what it was, or in FY 2020 was not what it was the previous year. So that's exciting to see. Do you feel like you had to like put the pedal down to make up that volume, or how did you guys recover so quickly?
That's a great question. You know, I think one of the things that was very unique to our institution was they tested everybody. So I should say that none of the patients that we did flaps on that I'm aware of actually tested positive for COVID. So the patients were all tested before surgery. So no patients had COVID. If they obviously had COVID, they had to be retested in 3 weeks' time before they were allowed to undergo any type of surgery, especially elective surgery. I think the other factor that was helpful for us is our regular floor beds, our nurses are willing and able to do flap checks every hour. And that's sometimes unique to our institution, which may be different from other institutions where they may require an ICU bed to have hourly flap checks. So if that were the case, I think we would have had much more difficulty restarting and ramping up, because to send a patient to the ICU for an elective breast reconstruction, I think would be considerably difficult and a big consumption of resources. But because our regular floor nurses, I mean, they're tremendous. They're able to do hourly flap checks for us. And our protocol is an hourly flap check for the first 48 hours. And then we transition to every 2-hour flap checks for the next 48 hours, and then every 4 hours before discharge. And I think the other factors is that it may just be in Texas and the mentality and culture in Texas, without getting maybe too political. I think maybe they were a little bit more cavalier about sort of the perception of the pandemic. So, we had a lot of patients who, as we said, once the restrictions were lifted, were really willing to come back in. At the time when the restrictions were in place, it wasn't as if there was a huge influx of patients and a huge wait list. The restrictions were in place, but there wasn't a huge number of patients that were even willing to undergo their elective breast reconstruction. But once the restrictions were lifted, I mean, Texas, you probably know, opened up very quickly. With the restaurants, other social activities. So I think that may reflect part of the culture of the region, aside from sort of some of the logistical things that the institution was able to do.
So I have a question, just perhaps more about the operations side of things. Now the wave that we're feeling is inability to have enough nurses. So we're really feeling staff shortages, and that's impacting our ability to do the number of flaps, the demand, to address the demand. What's your experience with that?
Yeah, that is a great question. We have had a bit of turnover. Again, MD Anderson really tried to do a great job during the pandemic. We did not have any furloughs. We did not lay anybody off. They did not have any salary cuts. So they really tried to maintain, the salary line for all the employees. Despite that, we do have a little bit of a attrition rate right now, as you say, with nursing staff. Other institutions offering, who did have to, I guess, lay people off, now want to recruit, staff back. And we do have, other hospitals in the immediate Texas Medical Center offering bonuses and, sign-on bonuses and things like that. So we certainly are witnessing, especially in our OR staff, there's an attrition rate as well. But hopefully we're able to maintain and keep some of the talent by sort of making competitive adjustments to prevent people from leaving, because, as you guys all know, you guys are a really high volume institution. You guys still do a lot of head and neck as well. We're only as good as the whole team, the plastic surgeons, the residents, the nursing staff, the scrub techs. And I think your success rates for plastic surgeons are, equally good, if not better. And I think it's a whole team effort that really you have to have in order to maintain that level of care and success rate for these complicated patients.
So one of the things that we had looked at was nosocomial infection rate, just because, clearly Hopkins has a big emphasis on safety. And fortunately, we don't think that anybody contracted COVID from being in the, undergoing a flap surgery with us. Mm-hmm. Did you look at that as well? What was your experience?
We didn't look at it specifically, but I think they took a lot of precautions. So everybody got tested within, initial at the time, I think it was within 72 hours of surgery. And if they didn't have a test, they could not even undergo surgery at all. So all the patients that I'm aware of who had a free flap microvascular operation were negative. I'm not aware that we performed a free flap in any patient that was COVID positive. So I'm not aware of anybody, patient actually getting admitted into MD Anderson that then spread it to other people. We did, interesting, have employees, unfortunately, who did contract the virus. And there again may have been interactions on a social level at the time where employees may have given it to other employees, but not any patient spread that I'm aware of. I'm sure Pittsburgh as well took very strict precautions and isolation of patients who were, so we dedicated an entire floor to patients that were positive. We did not see a lot of patients that were COVID positive because we're a little bit of a specialized institution. So we didn't have an open door policy where we had a huge influx of COVID positive patients. But the ones that were positive were in a strict isolation ward in the institution, and everything was designated with the positive pressure rooms. So there were kind of these in place, but we didn't have a lot of patients, I think, to begin with, compared to many of the other hospitals in the Texas Medical Center.
Some of the concern about pre-flap specifically comes from this idea that perhaps the virus promotes a prothrombotic state that may last even beyond the infection. There was some data at the association meeting about potentially a few weeks actually after that, up to a month, where there might be a increased risk of flap failure. The numbers are really small, and it sounds like you guys didn't see that, but would you have detected that? You said none of your patients had COVID, but was there any way to know whether they had COVID previously, or?
That is a great question. Great question. We're actually looking at that now. I anecdotally did operate on one patient who had a previous COVID infection. They again are tested again before undergoing their upcoming surgery, before any surgery. So at the time they had tested negative, but there was documentation of COVID positive patients. Again, I think the numbers are very, very small. The patient was a head and neck patient where we sort of decided that we couldn't really delay her resection and her reconstruction. Her test was negative, so we proceeded, but she did have a previous documentation of a positive test. She actually did remarkably well. I think to your point, I think the critical details, even if we're limited numbers, would be to see how many and at what time frame we waited from their actual infection resolution of symptoms before we actually proceeded with the surgery and the free flap.
I think overall it sounds like the bottom line is that doing surgery, and even high risk surgery like microvascular reconstruction, was safe. And this, hopefully this is the end of COVID with people getting vaccinated. Number one, it might not be, and number two, it's not the last. Sadly, I don't think it's the last. With globalization and this is unfortunately probably not the last pandemic. So I think it's important to look back and learn from this, and understand that we can do these surgeries in a safe way, even even when there is a concern about this. And I think probably what we need to do is get to, like you said, the numbers are small, but get together and publish these results so that we don't have to have such a dramatic shutdown of these important procedures next time. So
no, I agree with you 100%. That's a great point.
So I did have one more question. So you mentioned the slight uptick that you had in the delayed flap complications. And so do you think telemedicine could have had a role in that, or were you definitely seeing these people in person at that point?
That's a great question. We were seeing people in person at that point in time. One of the issues that we thought was an issue, or at least that we found, was we did not allow family members or visitors in the hospital. So we were really tight on restrictions. And our nurses are great. This is not a dig on the nurses. They're great. They work really hard and they are very diligent at flap checks. But a lot of times, patients, family members that are there with them actually learn, about flap checks. They recognize when something's not right. They recognize if there's, increased swelling or potential risk for bleeding. And there was a definite case where, unfortunately, the patient actually passed away. There was somebody had checked on him, but then nobody was available to check on the patient again. And then the next time they found him, unfortunately, something had happened. Either he fell or had an event. And unfortunately, the patient actually expired. So, in terms of the delayed flap loss, we were still seeing them, and I'm not really sure exactly what went wrong. It's none of the patients were COVID positive, to suggest a prothrombotic phenomenon that may have contributed to the flap loss. But it's just very peculiar. We literally saw 7 in over 7,000 patients. You're talking 0.001%. And now this year we had 3, which I think is a little peculiar, but hard to determine exactly what the underlying cause was for these complications.
Well, I think that is a really intriguing idea, this concept of that family support or social support. And I'm very familiar with that in terms of screening patients for our transplant or vascularized composite allotransplantation interventions. But that's really interesting that we should also consider that for other complicated surgeries.
Yeah. And we still have those restrictions in place. I'm not sure if you guys also have those restrictions, but we still have those restrictions in place. And, it's hard for family and it's hard for patients to go through these operations, not having somebody with them. And it's in part support, but patients get pretty savvy and their family gets pretty savvy about checking up on things, especially the flap, and they oftentimes will pick up things. The flap color looks different. We have family members that will kind of just pick up the Doppler pencils that we leave in the room. They'll kind of check themselves and be like, oh, look, I found it. They're very happy with that. So it is very interesting, the value of having somebody else, a family member with the patients, I think.
Yeah, definitely something that maybe we don't always understand as much from our point of view, but how important it is to have somebody with you there when you're having these procedures done. That's it. All right. Well, I want to thank you for sharing the experience and hopefully something we can learn from moving forward, and hopefully never have to do that.
Yeah, agree. Thank you guys so much.
Thank you very much.
All right. We're going to move on now to the next part of our evening, and that's going to be our panel discussion. And for this, we're going to talk about the challenges of combined VCA, combining more than one type of reconstructive transplant at the same time. This is, I think, something that in the past was considered particularly dangerous, and there was some question a few years ago about whether this was something we should be doing, but we've had some intrepid investigators pushing the field forward. And so we're going to hear from two of those people tonight and have an opportunity for some discussion.
So our first panelist is Dr. Simon Talbot. He is an associate professor of surgery at Harvard Medical School and the director of hand transplantation there. He is board certified in plastic surgery and holds a subspecialty certificate in hand surgery. He specializes in general plastic surgery, hand surgery, and microsurgery. Dr. Talbot has a particular interest in hand and upper extremity trauma, cutaneous oncologic reconstruction, abdominal and perineal reconstruction, and body contouring surgery. Dr. Talbot's research interests include upper extremity transplantation, nerve regeneration optimization, psychosocial aspects of major extremity surgery, and device development. He is funded by the U.S. Department of Defense and runs research in collaboration with surgeons at Uniformed Services University of Health Sciences.
Great, thank you. I will share my screen and get going. All right, can you guys see that okay?
Yes, we can.
Great. So thank you for that very kind introduction, and thank you very much for the opportunity to speak today. I'm looking forward to a discussion with Dan as well. So a lot of this is a very short presentation from each of us, and then hopefully some discussion and questions. As Carissa mentioned, I'm the director of upper extremity transplantation at Brigham and Women's Hospital, and involved in the last 4 upper extremity transplants we've performed, as well as a number of the face transplants performed. And my introduction to VCA was my first year in practice with a combined hand and face transplant that didn't go exactly as planned. So I'll give you the background to that in a minute, but I wanted to start off with just 3 very short slides, which is essentially all the literature on this to date. The first is a paper from Dr. Semenov's group back in 2009. So this was really in the very, very early days of VCA in the United States. And this was about multiple VCAs being performed together, but they really were talking about far less than we mean when we typically mean a multi-VCA. I think most of us, when we're talking about multiple VCA, think about hands and face, or face and legs, or hands and legs. This was really talking about using more than one site. So they were talking about things like using a sentinel flap. So doing a radial forearm as a sentinel flap at the same time as a face, for example. So they discussed any simultaneous flap that was being performed. And this was a very thoughtful article talking about a lot of things that have come up throughout all of VCA. So the surgical and technical challenges, just doing the operation and having multiple sites and multiple surgeons, the medical challenges, such as the immunosuppression, and of course the donor challenges of a donor who has multiple tissues to give, or multiple sites to give, while typically at the same time being an organ donor for solid organs, and the challenges that can create in negotiating with a transplant team, or at least the solid organ transplant team, how you're going to manage the donation of those various tissues. The immunologic challenges, particularly when you have two potential donors, if you're not doing your two flaps at the same time, of course, you're likely to have two different donors, and those two different donors are going to have two different immunologic challenges to your patients, and presumably, although not proven, a higher chance of rejection or complications related to that. The rehabilitation of different sites, the cost of doing this, presumably cheaper to do this one major operation than two fairly large operations, the ethical challenges of doing this, the psychological issues, which are probably less for this than we might have thought to begin with, and of course, patient selection. Following this, we went ahead and performed our first combined face and hand transplant. And the picture of that's in the bottom right of here. This is a patient who was attacked by a chimpanzee, lost her face, lost her hands, underwent these simultaneously, developed sepsis in the few days following surgery. And as a result of that pulmonary sepsis, ended up losing her hands, fortunately did not lose her face in spite of being on pressors. We spoke to our colleagues in France who had this additional patient who's shown in the top right, who actually passed away about a month after their surgery related to hypoxia. And we went through these two cases and really tried to dissect them, and came up with a few lessons that really struck us as being very important in both of our cases. The first was pulmonary protection. Our patient probably aspirated. At some stage during this, we actually use suction ET tubes now. We also get x-rays of our patients in the preoperative area and repeat labs and urine testing to be sure that they don't have something occult that they're coming in with. It's, of course, very important to limit blood loss. And this was certainly true in the French case, with a substantial blood loss that not only requires, it puts a lot of stress on your patient, but also requires the additional transfusion of blood that can be an immunologic stimulus to the patient. And so we also use cell savers now when we do these cases to prevent the need for additional blood. Operative time, critically important. Of course, these patients get sicker over time, they get colder over time, they clot less over time. And so in addition, the most recent case that Bo undertook, actually they stopped partway through the face transplant, took the patient to the intensive care unit, stabilized them and brought them back shortly thereafter. And I think that's a really interesting approach and lesson to learn from this. Of course, limiting tissue ischemia, critically important. In the second to last case that we did, we actually had pretty extensive ischemia time, just over 4 hours, and ended up having quite significant hypotension when we took clamps off and reperfused one arm. And so just like the vascular surgeons, doing this slowly in a stepwise fashion and minimizing your ischemia, especially your warm ischemia time, insofar as we even operate on ice when we're doing these cases now with a little ice block with the hands on it until we get them reperfused. Aggressive infection prophylaxis is something we're very keen on now. And then if all goes wrong, making the appropriate decision to debride and remove limbs. If you look in the bottom right, you might suggest that we waited a little bit too long. When things aren't going well, you've got to be thinking about your patient's life rather than the appearance of their limbs. So this was actually the critique, or maybe just the commentary from Jamie Shores, Andy Lee, and Carol Brandecker of the article that we'd written way back in 2013. So we're talking a pretty long time ago now. At that stage, they were saying, well, we should ask ourselves, what can we do and what should we do? And that was based on the fact that if you combine our case, the French case, and two cases in Poland, there was a 75% mortality of these patients, a 100% limb loss of these patients. And, you know, there was real concern about what was going on here. And of course, none of us were proud of our results, but we're very welcome to discuss this. They made a very important point, and I would stress the accuracy of this point, that patient selection is just so important, starting with a pretty healthy patient, minimizing any comorbidities. And this is not an operation for every patient. Meticulous preparation, planning, and experience. I'm sure Dan will talk about that. We do a ton of cadaver labs. We make sure that everybody knows exactly what they're doing. We have checklists for every member of the team to make sure that every member doing something knows exactly what they're doing to minimize the downtime and to maximize the uptime and the efficiency of what we're doing. And then really transparent discussions between the different teams, particularly the other organ donation teams and organ recipient teams, and with our patients, so that they know that, and I have a very honest conversation with them every time, that at any point, if things don't look great, we are going to stop this operation and we are going to respect their life over their limb or their face. So with that, I will wrap up because Dan is going to be speaking about what is now the first successful multi-type VCA. And I'm really looking forward to hearing what he says. Of course, my thanks to our spectacular team of surgeons, as well as occupational therapists and anesthesiologists and dermatologists and occupational therapists and people who just make this all happen. So thank you for your time, and I will hand over to Dan.
All right. Well, thank you for that discussion. I would say, you know, this represents the first partially successful combined. You know, so but I appreciate your you know, walking us through you know, how these things don't always go according to plan and what we can learn from that. Our second panelist is Dr. Daniel Cherardini. He's an assistant professor of plastic surgery at the Hansard Weiss Department of Plastic Surgery at New York University Grossman School of Medicine. He completed general and plastic surgery residency at NYU, as well as advanced fellowship training in both basic and translation research, as well as clinical reconstructive microsurgery. Dr. Cherardini was recruited as the Director of Research at NYU and is currently the co-director of the NYU Regenerative Medicine Program, and still manages to maintain an active surgical practice in aesthetic and reconstructive plastic surgery. He's the Chief of Plastic Surgery at the VA, New York Harbor Healthcare System, as well as the co-director of the NYU Aesthetic Surgery Clinic. He's received a number of research awards and support from the Department of Defense, NIH, and American Diabetes Association, as well as other foundations, and is the author of numerous peer-reviewed publications and is actively involved in tech transfer. He serves as the scientific director of the NYU VCA program, as one of the core operative surgeons of the VCA surgical team, which has performed 3 successful face transplant procedures at NYU, including the one that he's going to tell us about this evening.
All right. Can you see me?
We can. We see your desktop.
Okay. Fabulous. All right. So first of all, Simon, I see you're taking my slides now. I'm going to remember that next time we talk. So thank you all for having us on this panel. I think it means a lot. And I'm going to speak briefly about our experience doing combined cases at NYU. I have no disclosure. Oh, I have this disclosure. I'm funded by the Department of Defense. So I would say in the development of NYU's VCA program, like many other programs, it takes a long time, literally years, to develop and result in something like this or a similar milestone in surgery. But now retrospectively, when I think about it and the challenges involved in it, I think most of the challenges actually occurred before we met any patients. And if I were to sum it up in a single word that would describe the challenge in getting to this stage would be pretty much everything. Everything, I think the saying goes, the whole is greater than the sum of the parts, but no one ever tells you that it's actually harder than the sum of the parts as well. And while there are many, I think the greatest areas of challenge were the organization and operationalization of the VCA program, particularly in reference to combined procedures. And this can be divided into technical and logistical considerations. Technical considerations, there are many, but just simply determining whether you have the technical expertise available to perform these simultaneously is certainly an important consideration among many. The logistical considerations are also numerous. One of the ones that we implemented that I think is important is transporting the donors to NYU before any procurement begins. And that allows us a lot of different opportunities to perform pre-op studies and procedures to optimize the donor, as well as to fabricate personalized surgical devices for craniofacial reconstruction and VCA, which we used in all of these cases. Certainly our partnership with Live On New York, which is our OPO, and broadening the donor pool because we offered to pay for transportation for the donors to NYU, that effectively expanded our donor pool to across the nation. So that was very important. In addition to those particular considerations, it's a commitment really, and I can't stress this enough. It starts with the patient. They have to be completely committed, as do the patients and family members in the support system. And this trickles down to the providers. In the combined case that we did, there were over 140 practitioners and countless staff that all have to buy in, just like everybody else does. And you cannot deny the fact that the institutional support and federal and foundation support is vital to the success of these programs, as well as the OPO. As Simon alluded to, having the organ procurement organization and the solid organ transplant teams on board with what you're doing, we found was very helpful. And as a matter of fact, our team reached out to a number of the solid organ teams that were in the area as well as in the region, and gave them talks about how we envisioned this proceeding so that we could do the procurement first, seeing as we were bringing them to our institution, the ideal control conditions were in place, and that we could be successful. And they were actually very open to it. There was very little pushback. And finally, the industry technology and support. Obviously, we're using novel devices, so having the industry support and their turnaround time of 24 hours to provide us with customized jigs and devices was critical. So we'll go on to the recipient so we can leave room for discussion. He's a 21-year-old male, right-hand dominant, otherwise healthy. He was driving home from work after a late night shift, was involved in a motor vehicle accident where his car flipped over and caught fire. He had 80% total body surface area burns. This happened 8 months prior to his presentation to our program. He underwent multiple debridements, skin grafting, and additional reconstructive procedures at an outside burn center that he was airlifted to. And then he presented following discharge from that to our program. This is Joe. Joe is a sharp-looking young man from New Jersey. And this is him on the right after his accident. You can see his car still on fire in the background. You can see this is a devastating injury for a young, otherwise healthy person who is going to be impaired by significant quality of life issues, functional issues going forward. So this is what he looked like when he presented actually to our program. And you can see there's extensive facial scarring and the deformation of the cartilaginous structures. His eyelids are basically non-functional. He has no corneal protection, although he did have vision and his levator function was intact. His oral confidence was compromised. He has neck contractures. So there's a lot of issues going on specifically with the face. But then these are the hands, again, markedly scarred. You know, he lost most of the length on his digits due to auto amputation and had severely limited motion of the MCPs and at the wrists on both hands. So he was evaluated a number of times, both on an individual basis and in the context of the core surgical team, and discussed as whether this was even a possibility, whether we should do it. But we reached an agreement fairly quickly. Again, patient selection is critical, and this was a very highly motivated patient who didn't have a lot of other medical problems going on. So it seemed like a logical choice, at least from a technical perspective. But then it needed to be included in the entire program, which includes psychosocial evaluation and support evaluation, in addition to a number of other practitioners. And it was universally accepted that he should be considered as a candidate for transplantation, for a combined transplantation procedure. So the next order of business was to begin to rehearse the procedure, as Simon also alluded to. And we did a number of rehearsals to get down the workflow and the sequence of the operation, which was one of the technical hurdles. We had to figure out how to do it in order. And this is, we had 11 of these comprehensive rehearsals, and these were mostly done in the operating room. And it literally consisted of everyone that was involved in the case. As you can see here, this is actually not even everyone because they couldn't fit into the frame, but literally everybody that would be involved in the case was there. And look who shows up, Ken Langone, right in the middle there. You know, it turns out he can actually operate. You know, personalized surgical devices for craniofacial VCA. It's coming to a Home Depot near you, the weekend DIY warrior. But it's this kind of support from the people that effectively run the place That is very important to show that they're committed and to instill commitment in everybody on the team. So this was very important. We repeated this again 11 times. What we came up with for the plan, and we've done this in previous facial transplants, is we were going to take calvario bone as well as craniofacial bone in order to support the skin of the facial allograft so that it doesn't undergo ptosis over time. And so as you can see here, we had a number of 3D custom surgical tools designed and fabricated in 24 hours after the donor arrives to exactly match the recipient. This is a significant advantage to having this turnaround time. And as you can see here, there are a number of novel jigs. Some of them are adjustable actually. And calvario bone this is one of the first times it's actually been taken. And again, this was to support the soft tissue. We had never done a hand transplant here before, but we had learned a lot of very valuable lessons from facial transplantation. So we applied those to the hand transplantation and also used custom cutting guides for the hand transplant as well. And these were designed in the context of the hand side of our grand surgical team. So here you can see the donor plan and the recipient plan, and then the planned outcome and the transplant outcome, and they're pretty close. Just an overview of the room. The rooms are chaotic, as you might imagine, and this is a very, very simplified schematic of what it looks like. But there are basically 3 teams, 2 hand teams and the face team in each room. And the recipient room is kind of a mirror image of this. And this was designed specifically so we could facilitate solid organ transplantation after we finished procurement. So the setup was planned with all the solid organ teams as well. And I think that's very important. So the sequencing, again, as I mentioned, we transport the donors to NYU. And there they undergo all the preoperative procedures, imaging, catheterizations, evaluations, and then the devices are designed. And this has been, we found this to be important actually in a couple of cases. And the one on the bottom right is one of the face transplants we performed, and the facial vein actually arose from the anterior jugular system, which is an uncommon variant, which was actually pointed out early and allowed us to kind of safely make the dissection of the allograft and in an expeditious way. The recipient is also transported concurrently and undergoes all the preoperative procedures and prep. It's a 6-team simultaneous start. The facial donor procurement includes bilateral neck dissections to get out your pedicles, all the craniofacial exposures and nerve exposures if we needed them. We didn't in this case. The bilateral eyelids are dissected free, carrying levator with you, and the devices are placed and osteotomies are made, and that effectively completes the facial donor procurement. The upper extremity procurement, interestingly, we did, it was not under tourniquet control, so there was no tourniquet ischemia time for the limb procurement, and that's kind of a risk-benefit judgment that you'll have to make, because obviously ischemic injury is one of the predictors of acute rejection in the post-op period. So we wanted to minimize that, and the fact that we were in rooms that were adjacent to each other, we wanted to minimize ischemia time period. And then passing over multiple segments of VCA tissue, the right hand went first. It was the dominant hand, had the worst injury. We wanted the outcomes to look good there before we proceeded with the left hand in the face, which went over in that order. So these are just some operative pictures. This is the face coming off as the final event of the donor procurement, as well as the hand. This is the right hand. As you can see, we pre-plated the donor hands onto a stereolithically casted bone from Joe, so that we could ensure that we could have an expeditious osteosynthesis on the other side. In addition to using 3D to make the surgical tools, we also, in order to maintain the dignity of the donor and respect their contribution to life, we also 3D printed the donor mask and the prosthetics for the limbs as well. And they actually turned out with quite high fidelity, and we're very happy with those. The op report, it was 23-hour operation. Donor procurement was done after 12, 13 hours. The fluid resuscitation was normal from what you would actually get in an operation that long, a typical replant. There were approximately 10 to 12 units of blood given, as well as products. The immunosuppressive regimen and prophylaxis was pretty standard. The only thing that was somewhat so we used thymo for induction, and we also used rituximab, which is an anti-B cell agent, because the panel reactive antibody panel was high in Joe. So we used that. We've actually used that in all three of the transplants that we've done at NYU. And I think the paper's out already on that, but it's still an N of 3, but seems to be favorable. So this is Joe. Joe, this is when he presented to us initially, and this is Joe 6 months after his transplant. And you can see, you know, he's obviously had viability of his grafts. He was actually one of the most motivated patients we've ever experienced. He was very avid about working out. He worked out before he had the transplant, so he wanted to get back into it immediately, which was fantastic. He does a lot of gym work, a lot of bag work in the gym, and he's postured here like Rocky, which is one of his idols. So that's why you're going to see him postured like this for the rest of the talk. This is his face up close. Again, a pretty good match. Notably, the donor had a very large face, a very large skeleton compared to Joe. So we have a little bit of an excess of tissue that we will eventually take care of, but at this point, he's doing fine. This is the lateral view. You can see we maintain bony projection of the chin point as well as the nasal complex. These are the hands. We went all the way up to the elbow. He had an elbow contracture that we fixed with the dorsal skin flaps. He has excellent hand function. He's lifting weights. I think he's up to 10 pounds per arm at this point. He's, again, very active in the gym. This is the right hand, same concept. You know, very, very good function. And then in addition to generating the actual constructs, the devices, we can actually use it as an outcomes measure as well. These are overlays of what we planned versus what we actually did. And you can see the overlays are pretty close, except for the right-sided calvareal segment was a little bit off, and that was adjusted intra-op based on the location of the actual ligaments that went to the skin. So that was adjusted intra-op. This is a progression of Joe over 6 months since the operation. So that's pre and then post for, I think, approximately once a month after his transplant. So he's doing quite well. This is him reintegrating back into society with things that he does, that he likes to do, activities of daily living. This is Dog Buster. He likes to play pool. He likes The Godfather. And he's from Jersey. So the lessons learned, and Simon, again, you know, and everybody on the call probably knows this, that early formalized organization and operationalization is critical. It has to be an iterative process with multiple sources of quality improvement. You have to have buy-in from the institution. You have to, and funding organizations in order to make this possible. Although the most recent cases we've done, we've had a lot of insurance reimbursement for, which is again a positive sign going forward. You have to assemble a team that shares the commitment to a larger goal, and that includes everyone, not just the surgeons and the practitioners. It includes the staff, and really that's kind of comes from the top. And then you obviously have to recognize this not only as an innovation as a surgical procedure, but an innovation for new technology. And so with that, I'll conclude. This is our team. Obviously, it's very big, and I look forward to the discussion. I think this is an important topic.
All right, fantastic. Thank you for that overview of the case. Very impressive work, and in a tremendous team. I mean, it's amazing to see, you know, the surgical team that you put together, and it just emphasizes the nature of this the endeavor and how you know how daunting a process this could be. With that in mind, you know, that's much bigger than the normal team that we have in our standard reconstructions. How did you, I want to hear from both of the panelists, how did you organize between the hand and the face team? Did you operate simultaneously? Was there checkpoints? Was one prioritized over the other? I'd like to hear from both panelists.
I guess I'll start. I think one thing to mention with the hands and the face is it's actually 3 separate microsurgical procedures. It's not just 2 separate sites. It's even more than you think about when you think about 2 separate procedures. So we have a sort of a arbitrary division in our division anyway between the hand surgeons and the non-hand surgeons. So it wasn't very difficult to pass our group out into those 2 categories, and then we just simply assign people to specific tasks. So when we do our hands, we have 2 people on the left side for the recipient, 2 people on the left side for the donor, 2 people on the right side for the recipient, 2 people on the left side for the donor, and the same for the face. And then when they come back to our hospital and everybody's working together, then people can start to take breaks, and we just have, 2 people at a time plus our residents and fellows. Dan actually mentioned at the beginning of this that an unbelievably important part of this is the logistics and the organization and the communication and the way that you get everybody working together. And that's the reason for the cadaver labs. That's the reason for the discussions. It's the reason for the checklists. I think that's the hardest part of all of this, is just getting everybody working at the same time, in the same pace, at the same place. And frankly, the rooms aren't really designed for this. Even our largest operating room, only has so much space for C-arms, microscopes, cell savers, all the anesthesia equipment. And then, a patient is only at best, 6 feet tall and 2 feet wide. There's only so much room around the patient. So I don't know, I'd be interested in your thoughts, Dan.
Yeah, I mean, I totally agree. We had extensive checklists, almost to the point where it was onerous to go through the checklist and make sure that we were getting everything in sequence. But it was important. And in addition to that, we not only had the checklist that the surgeons would check, but we had actual attending surgeons that were responsible for oversight. So they would run back and forth between the rooms to communicate where they were having problems, where they weren't having problems, their hands ready to go, the other hand's ready to go. So that kind of communication, we actually designated someone to do that. In addition to the research staff that we had, that was kind of like tabulating everything, keeping track of everything. There was like multiple levels of oversight. So there has to be checklists, and the protocol. I mean, we have the same kind of setup. We have 3 around the face instead of 2, but for the most part, it's the same. You have 2 teams, 2 surgeons on each hand, both in the donor and the recipient room. And I can tell you that some of the hardest challenges in dealing with that is trying to figure out amongst the hand surgeons how to put the tendons together, or what's the right osteosynthesis. It's like everybody has a different opinion. It's like pulling teeth. But yeah, the checklist phenomenon, and that the fact that you really have to operationalize things and over engineer it, I think is really, really important. People don't understand how much goes into it until you actually have to write it.
Yeah, and there's all these things that you've never even thought about until you've done it in the cadaver lab. You do it in the cadaver lab and you're like, oh geez, all these tags get tangled up in one another. What are we going to do to prevent that happening? And so like when you've done, an operation 10 times, you've figured out most of those things, but these are operations that you just don't do that much. I think one of the other things that you guys did, Dan, that's just spectacular and you should be really credited for is figuring out how to get your patient into the same hospital. Where we are, one of the challenges has been that there was incredible, I don't know if the word is pushback, but incredible reluctance to allow a patient to cross state lines. And the reason is, at least the way I've been told it by our hospital lawyers, a patient who's brain dead is by all intents and purposes deceased, and crossing a state line with a deceased body has its challenges legally. And so, if you've got somebody in the same state, it's certainly possible, but there is a very good justification, if this continues, to look at legislation that would allow unique situations like this for patients to be transported even after brain death.
Yeah, I think it went to legislation in New York. I think that was part of the push, is that we had to bump it up a bunch of times to the highest level in order to be able to do this. And again, the donor for this particular operation came from Delaware. So, and the fact that we were paying for the insurance and all that stuff, I think really kind of helped things along in order to make that possible. But yeah, we were actually evaluating patients like literally from coast to coast at some point. But it is something I think that really, if you're going to stack the deck for success, having them in the same hospital and being able to kind of like optimize things for both the donor and the recipient in the 24 hours before surgery is really big, really big.
Yeah.
I know at our program, we had a pretty complicated case that we were working up and had arranged. We were had permission, and I remember all the steps that went into just being able to get the donor into our hospital, wherever it came in the state of Maryland. But yeah, outside of the state of Maryland, it was not happening. So I can appreciate the legwork
that went
into that.
Yeah, that was a victory for sure, but it's also a precedent, as you know, as we were talking about.
That's great.
And I think it will facilitate, because you know, obviously the donor pool is a little bit restricted, certainly when you're talking about skin tone alone. So you can expand it a little bit by accepting both male and female to a male or female recipient, which we also did. But you know, being able to kind of transport across state lines, I think would really help people like find donors a little bit easier. Because this one took us 9 months to find, but Patrick, who was our first face transplant, that was 18 months before we had a donor.
We've had challenges in that if you come to Massachusetts and you have a life-ending event, you will probably spend an extended period of time in an intensive care unit with multiple procedures being done, and you will not be a very appropriate organ donor at the end of that. And so almost all of our donors have come from north of here. And so it just happens that there just aren't that many appropriate donors in our local area because of the intensity of medical care that people receive locally, which is a bizarre irony to having a complex medical place here.
Yeah.
And I just want to take a moment to remind, you know, folks who are still staying with us here, you know, please enter any questions that you might have in the chat, or feel free to, you know, unmute and turn on your video, and you're welcome to interact with our panelists. You know, very unique opportunity here.
So you've talked about how the you know, unbelievable logistical challenges of doing a combined transplant. Is there any role for not doing this on the same time, accepting separate donors and staging? Obviously, there's some immunological issues there, but that would be simpler from an operational standpoint. Any thoughts when you were working these patients up on splitting up the transplant?
We personally didn't. It was, I think that was it was part of the buy-in kind of deal, I guess, would be that we would do this I mean, you know, we did the financial numbers and it changes every single time we do it, but it's pretty expensive. So I think the thought was that we would do this. And again, because even though we hadn't done a hand transplant, it had been done and successful. So there was enough kind of evidence to convince them that we should try a combined procedure. As far as the immunologic issues are concerned, I'm still not convinced that's the right thing to do from different donors anyway. I mean, we don't even know, you know, until we get rejection with a combined allograft, we don't know if the hand functions any differently than the face, or whether there are different immunologically privileged areas or not privileged areas. So, so I think the jury's a little bit still out on that. I don't necessarily think that it won't ever happen, but I wouldn't feel comfortable doing it personally.
Yeah. So I would underline that even more, which is I don't think we have any reason to think that they would be immunologically privileged. Yeah. I think we have pretty good evidence from the chronic rejection that we've seen that hands and faces work pretty much like all the solid organs and follow that same pathway, and that there's no good reason why, just because they happen to have multiple tissues, that the vascular endothelium should respond any differently to an immunologic challenge. So I think there's definitely a downside to it. Our own, this has come up with us because although no one has successfully done a multi-limb or upper and lower extremity transplant, we have had, you know, quad amputees who have been interested in upper and lower at the same time. But the difference between that and a face and hands is that, number one, you're transporting a lot of bone marrow, which has certain immunologic issues related to it. And also you're bringing a lot of tissue volume. So if you've got a high above elbow and a high above knee, you're bringing in, you know, a third to a half of a human volume, which just by virtue of, you know, blood volume alone and ischemic tissue alone is an incredible challenge. And that's really, you know, we haven't been able to get hold of the Poland team to talk to them about it, but I think there's an element of that goes on. And so we have looked at doing a lower extremity transplant in one of our upper extremity transplant patients. I've been very, very reluctant all the way along. And I think when this patient saw my reluctance, he was like, hey, I'm okay. I'm okay. I'll keep going with prosthetics. And I'm kind of pleased that he made that decision. But that we have looked at it and had some reservations for that reason.
Yeah, I mean, the other issue that you brought up was, differential rejection. So that's another question that's going to come up. What happens if you lose one of these grafts? Are they, how do you address retransplantation, which, you guys have some experience in.
Yeah,
but
showing us up here.
But that's but I'm just saying that's an interesting, that's a big question all by itself. But now what do you do if you have a differential situation?
Well, I think the interesting situation that's happening now is there are a number of hand transplant patients and, in fact, a head and neck transplant patient who have had to have kidney transplants because of kidney failure related to their immunosuppression. And so then how do you prioritize them in this situation? They are probably more likely to lose that kidney because of all the additional antigen that's floating around in their system. And how do you make sure that you maintain enough immunosuppression to keep that kidney going while at the same time not creating secondary problem? I mean, although a second VCA or two VCAs at the same time have their challenges, the life-saving aspect of a kidney concurrently, I think, is a worthwhile thing thinking about, because there will be more of our upper extremity transplant patients who need kidneys over the next 10 or 20 years for sure.
So maybe we should give them a kidney from the donor too, just the extra. Just
a third.
The old 3 kidney technique.
Just a spare. It's good.
Yeah.
All right. So this has been a great panel. We are getting a little bit later into the evening. If we don't have any other questions from the group, let's see.
Oh, Dr. O just sent a message. Amazing work. As a 100% pediatric plastic surgeon and craniofacial surgeon, I'm largely spared of these particular challenges. What are the thoughts of the presenters on expanding these procedures into children?
Yeah, that's an interesting question. We, when we first pitched this, we were going to try to include children because, much like all of our institutions, we see a lot of craniofacial stuff that isn't really amenable to conventional reconstruction. So we started the foray into it. It just became, from a regulatory perspective, a little bit difficult to do. Do I think it's going to eventually happen? Probably, but I think that's a little bit farther off. And once we, I think the next kind of step will be not doing larger transplants, but doing smaller transplants, and how you can make a small transplant like an eyelid or the eye unit or eyelid unit, be a functional transplant and not, spend like millions of dollars to get that one unit in. I think that's the next wave, and that will benefit the pediatric population significantly.
I'm enthusiastic, and I am pleased to see people looking into it. I got to say that these are massive operations with massive numbers of complications, and the complications don't stop just because you're 5 years out from surgery. You've got avascular necrosis, you've got complications from viral issues, you've got complications from your immunosuppression, you've got renal failure, you've got diabetes. And so any child is being exposed to this for an extended period of time. And I think given that most of us believe that any VCA has a life expectancy on it, I'm not sure I would put my child through a VCA unless I felt like they had no other good or reasonable chance. And so my personal take on VCA has been, we started out saying we want patients who get the best results, and those are patients who have hands that are amputated at wrist level or the most distal transplant. I've changed my opinion on that dramatically, and now I feel that the only people that are worth taking on all those risks and all those complications are the profoundly disabled people who have an amputation high above elbow and can't use a prosthetic or don't have any other good options. And for them, it becomes, although their result is not as good as the distal transplant, it's the only thing they've got to be functional. And so children fall into the category where I might consider it, but they'd have to be, I wouldn't be doing a unilateral or a distal or anything like that in a child myself. I know other people feel differently, and I think it's very interesting, the potential for immune system modulation and things like that. But again, it's a very experimental area.
Yeah, for me on this one, so I'm the person who handles our IRBs and getting things through, and getting all the information and collating it, and just from a administrative standpoint, I've not wanted our group to get into that.
It's a nightmare.
What my personal opinions might be, but it's a lot of work.
Yeah, Yeah, for sure. It's a lot of work doing just the face or just the hands. I mean, the pediatric regulatory stuff is just way too much.
Yeah, a whole nother level of risk and consent and family dynamics and
you know, and that's maybe the situation where the patient's already immunosuppressed or something else, like Scott Levin's group, who had a patient who already had a kidney transplant and was already immunosuppressed. It does bring in that multi-VCA issue again and immunology behind it. But I think it feels a little more comfortable to be doing that to me than starting from scratch with a child.
All right, well, I'm going to ask one last question to round out the session. And, Simon, you mentioned the fact that, perhaps the patients that can be best served by this are the ones that are the most challenging. And certainly I would say these combined VCAs are in that group. But it's, you've both highlighted how difficult this is. So I just want you to, a capstone comment. Is this something we should be doing? Are we pushing the envelope, or is this a bridge too far? Doing these combined procedures, and is there a place we should stop, or should we keep doing
keep pushing?
I see Dan frowning as well. My take on that is I think these are case-by-case situations. Every now and again, you come across someone who's just a perfect candidate, knows the risks, gets the issues, and you've got a perfect donor and everything, the stars align. This is one of those situations where you don't take chances that you can't at least see as being reasonable. So I think this is not pushing it too far, but you just have to be cautious and careful and very, very patient as you go through the process.
Yeah, I agree. I mean, I think you have to make these steps in order to prove feasibility and safety. Ultimately, I mean, obviously they're fraught with complications in the long term, but I think in order to make these kind of strides as far as the actual technical procedure, I think is important. But I agree, it's like, I would reserve these huge cases for like ideal candidates, that really have nothing else going on. They're very, very motivated. And, like addiction is really a rampant problem in a lot of this patient population. So those would be the people that I wouldn't want to necessarily consider for these big cases. But yeah, I think they have to be reserved for the ideal candidate. And again, like I said, I think we should focus more on getting smaller stuff to work with less immunosuppression.
So we did have a couple of shout outs for you guys come through on the chat. Dr. Moore says, incredible work. Congrats to you both. Thanks so much for sharing. And I totally agree with that. And then also Mr. Akbari says, incredible work. As a junior medical student, this seems like science fiction, very inspiring. And I have to admit, as somebody who is very involved in our VCA program, I forget how out there this can seem. So thank you, Mr. Akbari, for sharing that.
Thank you.
It's our pleasure.
Fantastic. Well, I want to thank both of our panelists for a wonderful panel discussion. Again, in addition, I want to thank all of the speakers and all of the hard work that's been done to go into this session and capping our fourth night of the Pentathlon and making it a success. To add extra element to the Pentathlon program this week and to appeal to PSRC's social media following, Dr. Justine Lee and the members of the Research Council's Tech Committee have organized an Instagram live session for each night of the Pentathlon program. The Instagram live session will be a play-by-play of each night's programming, like sports commentary during a game. We'll call this the closers. The Instagram live session will take place immediately following the close of this presentation. And the closers may comment on the live panel or recap the highlights from that. So be sure to check that out and support Plastic Surgery Research Council on social media to get our message out. So again, thanks for everyone who's still here, and remember to join us tomorrow night for our final Pentathlon event on breast, aesthetic, and gender affirmation. Thanks, everybody.
Great, thank you.
Thanks, everyone. Thank you guys for moderating.
Our pleasure.
The PSRC Tech Committee looks forward to seeing everyone there. Thank you.